privilege of presenting our keynote speaker. Dr. Opusanjo is an accomplished public health professional with over 15 years of experience in community-based practice focused on health equity. She received her doctorate in public health and health promotion and behavioral sciences from the University of Texas School of Public Health in Houston. She currently serves as the executive director for Can Do Houston, which is a community-based nonprofit organization that advances healthy living and addressing systemic barriers to good health through community-driven solutions, and promotes health equity across Houston and Harris County through partnership and engagement with under-resourced communities. She has over 15 years of experience in community health practice, academia, and research. Her practice-based experience spans grassroots community engagement, capacity building, policy and system change, and leadership and advocacy training to promote environmental changes essential for facilitating the adoption and maintenance of healthy lifestyles. Dr. Opusanjo works in health promotion research, has centered around community-based participatory research, perceptions, and health behavior, and the impact of innovative community-driven solutions to the built environment and policies that facilitate active living and healthy eating. She is a Master Certified Health Education Specialist, MCHES, and a Certified Public Health. She has served in numerous leadership positions, which includes her previous service on the board of TSOPHE for over 10 years and across 6 different positions. Dr. Opusanjo is a clinical assistant professor and the director for the online MPH program at Baylor and the Department of Public Health. Her personal mission is to leverage existing resources and support the empowerment and capacity of underserved communities to advance effective policies and system change that will promote the opportunity for all communities to achieve optimal health and quality of life. Please join me in welcoming Dr. Opusanjo.
Good morning, everyone. It is absolutely a pleasure to be here with you. I just want to do a quick check and make sure everyone is able to hear me. Any chat?
Yes, we can.
Yes, fantastic. Again, good morning. I am Jasmine Opusanjo, and again, it's a pleasure to be able to be here, especially to be able to present at the TSOPHE Conference. Thank you for that introduction. Amaka, is great to be able to be engaged, especially given the duration of the pleasure that I've had to be able to be involved with TSOPHE. And so what I'd like to do this morning for the second day of the conference is talk a little bit about community engagement, community empowerment, and what it essentially means for us moving forward within our field of health education and the work that we do to advance health within communities. And so for the scope of how I'll cover just a couple of slides in this introductory session, one, I want to note to be prepared to type within the chat because there are a couple of questions that I'd like to pose and gain your input. And I know that I'm preaching to the choir of longstanding professionals, new professionals, students, all of us who are passionate about being able to work with and in partnership with communities to advance health. So some questions might seem a little straightforward, right? Or we pretty much know the answer, but I want to see how that's going to feed into our discussion through this presentation. And the general scope of that is because my challenge that I will leave us with by the end of this talk is how we really focus on redefining the infrastructure that we establish and that we do our work through in order to be able to achieve health equity. So on that note, a couple of objectives that I'd like to focus on for the sake of this presentation is one, being able to discuss health equity and its significance to our approach within health education. Also, would like to discuss the role of community engagement and community empowerment in health education, public health, and the achievement of health equity. And then I'll present a few practice-based examples of community engagement and community empowerment and leverage that to transition into what does that mean for us moving forward as we seek to advance health, especially in the midst of our current reality as we continue to work through the COVID-19 pandemic. So the first question that I know we have a variety of similar answers for is, if we were to define health equity, what would that be? And I want to present it with this caveat. If we were to put this in no more than 3 to 5 words, how is it that we would define health equity? So I'm going to pause for a moment as we type within the chat to see what responses are generated. I know I'm kicking off the morning with you thinking and having to engage. My apologies, but what are our thoughts? What is health equity if we had no more than 3 to 5 words to be able to use? Good. Quality healthcare for all, equal access for health for all, equal access and quality of care for all. Good. Improvement in community health, access, equal opportunity, leveling the playing field. Excellent. Any other thoughts on what is health equity? Opportunity to reach full potential, healthcare access for all. Excellent. So great points thus far, and definitely continue to add to the chat. But what I'm consistently seeing across our input is that how are we able to create spaces where we level the playing field, create the opportunity where everyone has access to what they need in order to achieve optimal health, quality of life, right? And so on that note, there's a couple of images that I'm going to show really quickly because we've all seen them. They've been presented in various spaces when we consider equality versus equity and what does this mean for the work that we're doing. For example, this one, and I think about the response that someone posted about being able to level the playing field. So we've seen this graphic that depicts equality versus equity. And we know that when we focus on equality, we are particularly focusing on making sure everyone receives the exact same resources, the exact same types of supports. However, what we do know is that by focusing on equality, that still results in a different outcome, right? It may not necessarily meet the needs of the individuals that we are seeking to be able to support so that they can actually achieve quality of life and optimal health outcomes, such as what's depicted here and being able to actually view this game. And so equity within this graphic and others that we've seen, the focus is on being able to, yes, provide resources, provide access, but realize the importance in understanding what that needs to look like for it to be as effective as is intended, which means the supports might look different, whether it's the allocation of resources, whether it's what will come from the restructuring or redevelopment of existing and new policies, whether it's the way in which we're providing care and distributing what distributing what those resources look like accordingly. We've also seen this graphic, again, same concept when we're considering equality versus equity. And the difference, yet again, is how do we make sure the work that we're doing, the approach that we're taking, the way in which we allocate resources is relevant to the communities in which we're trying to serve, so that everyone, regardless of who they are, what their background is, what types of financial resources they may have, they have the same opportunity to be able to achieve health. Another graphic, yet again, that we've seen presented via the CDC, where it is attempting to depict, okay, in order for us to be able to actually reach this overarching goal of health equity, what does that mean? Naturally, we need to be able to close the gap within the disparities that we see and know to exist. And for that to be the case, we need to make sure that whatever types of programs and initiatives that we are pursuing are designed in a way where they can effectively close that gap, which similar to the previous graphics that we were viewing, that means resources, allocation, structure would need to look different to achieve that goal. And then lastly, again, images that we've seen before, this one building on the previous images that I showed, equality versus equity, and then even taking things a step further for the concept of justice, right? And so these two are what we were seeing in our previous images, but to take things a step further, justice essentially helping us to focus on the root issues and really any systemic barriers that might exist. And how is it that focusing on those systemic barriers and seeking to remove those, what does that look like in relation to, allocation of resources and the work that we do so that we still get that outcome, but does it mean that there need to be these additional supports, or are we really trying to be more effective by addressing the root issues and removing those barriers? So just some concepts that I want to keep at the forefront for us as we move through this presentation, and again, focus on how we are redefining the way in which we approach health equity and what the infrastructure looks like in order to be able to do so. So we gather a sense from everyone's chat, increasing or creating access to the opportunity to achieve optimal health, quality of life. So now back to the chat. Since we've gathered that, and this is not any new information for us, let's think about what we would say is necessary in order for us to actually achieve health equity. So in the chat, few words, what is it that you would present as what is necessary for us to be able to achieve health equity? How do we do this? The concept sounds great, right? But exactly what does it take for us to be able to reach it? Continue using your voice. Measure and allocate. Like that. Other thoughts in the chat? How do we achieve health equity? Consistent funding and education. Definitely. Bringing resources to people where they are versus making them come to the resources. Fantastic. Centered around the people and the communities that we serve. More funding for community-based organizations that focus on healthcare access and care for underserved populations. Grassroots programs and community involvement, communication, advocacy for funding. Seeing a lot around funding and being able to support the work that we do, which is definitely very important. Having open and honest conversations with active listening, change with legislation, advocacy for communities. Fantastic. Thank you for your post to the chat, all of which are speaking to different examples of what can be done in order for us to be able to close that gap and start to make progress towards being able to achieve health equity. And so something to realize at the center of this, whether it's having the resources through funding, engaging communities, making sure that we are listening to what are barriers as well as what are solutions. In order to do so, I'm going to speak a little bit about a fundamental shift that is critical for us to be effective in achieving health equity. Leading into that, I want to begin with the social determinants of health. So if we are seeking to close the gap, we know that there are a multitude of factors that are impacting the individuals and the communities that we serve. And that even though right now, what is at the forefront for us is COVID-19, right? And we are seeing the detrimental impact that is happening across communities, and especially communities of color, especially communities that are under-resourced. And in order to seek to address what is going on and reduce the impact of this pandemic, we have been able to see the various ways that communities are impacted, which goes just beyond having access to vaccination or to testing, We know that's absolutely important, right? But let's broaden our scope to think about the other multitude of factors that are impacting our communities. Because although we have seen the unfortunate impact that has happened around COVID-19, we also know that it doesn't have to be the reality. And more importantly, we know that these differences in the impact in the midst of the pandemic are not new. We've heard this over and over again, where we are seeing certain communities, again, disproportionately impacted or who are suffering in a variety of ways, but this has been consistent over time. And so by us having a broader perspective on what are those factors that are contributing to health outcomes and where are the areas through which we need to focus our efforts, it requires us to be comprehensive and consider the various social determinants of health. These different social determinants of health, although they may present themselves differently in terms of the magnitude in communities, the point is that these are absolutely part of the conversation and that they're necessary to be the focus of the work that we do. Now, in addition to that, even if we know that, okay, social determinants are important, we want to make sure we consider those. We know that the way that we do our work, it doesn't automatically lend itself towards having a focus on social determinants. But if we are to do so, this naturally causes us to take an approach where we're being much more inclusive of community through the way that we engage them and the way that we advance the work and the solutions that we seek to implement, right? So for addressing the disparities that we've seen and closing the gap, we see those disparities across each of these different social determinants. And that's contributing to the outcomes that we're seeing, whether it's COVID-19 or anything else that we want to speak on. So by having community heavily involved in not just identifying what are the barriers, what are the issues, what is contributing to the disproportionate impact of COVID-19 and other health issues, the determinants help to create a space where we're automatically being much more inclusive and focused on community. And so on that note, when I want to think about inclusivity and focusing on community and engaging community, because at the very beginning, I noted that the focus of this conversation is how we engage community, how we focus on building or empowering community for the sake of addressing health equity. And so we think about the continuum of what it means to actually engage communities. This graphic, which I like to show, because one thing that often comes up is the differences in the way in which we define community engagement. Now, we might think, why does that matter? We already know engaging communities is important. Yes, but how we do so determines the way in which we are able to effectively or not address the disparities and the inequities that exist and ensure that the solutions are really centered around what is relevant for the communities in which we serve. So if we look at this continuum, which I know many of us have seen before, this spans all the way from informing to empowering. Technically, based off this graphic, these are all forms of community engagement. But what's important for us as practitioners is that we have to pause and kind of check ourselves in a way where we are able to be very candid in determining in what way do we really want to engage communities and in what way do we want that to really inform the solution, the change, the impact that comes of it. That matters because if we just use community engagement loosely as, well, everybody's engaging community, then we're really not doing justice to the differentiation that exists within this continuum and the way in which our approach to community engagement will really influence the outcomes. So for example, starting all the way to inform, of course, we know there's value added. There's importance in being able to provide information and inform individuals about problems, alternative solutions. However, to what extent is this a primary focus for the work that we do as it compares to more collaborative efforts, or the focus on there being empowerment in the way through which we interact with communities and the way through which they inform and drive solutions that are going to be relevant and necessary to address the issues impacting the individuals and their communities. So wanted to highlight this because I think this is valuable to always come back to as practitioners, to really think about, am I engaging community? Is this really a priority for me or the organization that I work with? And how is this presented in the work that we're doing? And how will it influence the outcomes that are to come? So all of that being said, thinking about health equity, what it means, what is necessary for us to be able to close gaps to actually achieve it, the role in which community engagement has in being able to close those gaps and contribute to that outcome of health equity. This means that it requires us to have a very critical shift in perspective. And that shift in perspective, one way to think about it is twofold. What is the evidence and who are the experts? When we consider working in community and trying to close the gap, we know and we are trained to go to the existing literature and existing assessments that have been done that present the case for, these are the problems, these are where there are gaps, these are where there are assets, these are recommendations for best practices and solutions. So we definitely know that that's important, and that is absolutely part of the conversation. But what I want to challenge us to do is make our perspective on the evidence much more comprehensive. And so when I ask the question, what is the evidence? How do we challenge ourselves from not only focusing on the scientific literature and the established recommendations within reports and the data that has been presented, given assessments that have been done, that is very critical. But when we only operate from the perspective that that is the evidence and the sole evidence, we are missing a whole nother component, which is where community is part of this evidence base. We know from the work that we've done, or maybe from what we've heard from others, there can be a very different perspective between what has been assessed and identified as the priorities and the needs, and the perspective of community in terms of the priorities, the needs, the barriers, and solutions. And since we are talking about how we work with communities to be able to advance practical, effective solutions that work and that are relevant, it is not possible to have that conversation and consider the evidence necessary for that without the community being part of it. So the question of what is the evidence is leaning on the challenge of, our goal needs to be much more comprehensive, where we're not treating one form of evidence as more important or higher than the other, but we're being much more comprehensive in what that entails, and that the community's input perspective is at the center of that and part of this evidence base. Along those same lines is thinking of who are the experts. We start with the existing evidence. We seek to, we know assessment is important. I mean, think about the areas of responsibility that are the foundation of the work that we do, right? We assess needs, we assess, and based off of those needs and those assets, and we seek to plan effective programming and implement it and evaluate it, and the list goes on. But if we only focus on walking through those steps, given what already exists from the traditional focus of the evidence base, then we indirectly identify a certain type of stakeholder as the expert, which can become, just us as health educators and public health practitioners, those who are able to provide the funding, those who are able to help advance certain interventions. But yet again, if we're not careful about being very inclusive and much more comprehensive about who are the experts, then we miss a key stakeholder that has to be involved at the table and part of this equation, which is the community. So how do we begin to shift to make sure we're viewing the community as the experts and not that there is some form of hierarchy where the evidence and the science base and the professional is more of an expert than the community. So both of these, again, these are my areas for challenge, right? As we move through the rest of this presentation and beyond, is rethinking what's the evidence, who are the experts, and the foundation for both of these is community and the way in which we make sure that they're involved, not just, hey, invite you to the table. How is this just part of the infrastructure that is set up where it is commonplace and there's no way to be able to advance the work that we do without it being driven by community? So real quick, I want to shift over and provide just a few examples of some of this work within practice, and I'll highlight some examples via CanDo Houston, and then circle back to how this all connects with shifting in perspective and community engagement and community empowerment. So CanDo Houston is a community-based organization that focuses on being able to advance healthy living through community-driven solutions. And with that being said, the idea through the work that we do is CanDo Houston doesn't have its own set agenda, right? The idea is that there is consistency in terms of the model and the approach that we take to the work that we do within communities, but that outcome can look very different depending on which community we're working with. So if there are 5 different communities in which we are engaged, and let's say each community is experiencing issues with access to healthier food options or just accessing food altogether, given that being something that has been at the very top due to the impact of COVID-19, well, what does the solution look like? And how is that solution not something that is generated by CanDo Houston, but it is through the engagement with the community to understand the relevant solution in this community looks like this, while the relevant solution in another community looks very different. And so our work, our goal in partnership with community is to be able to advance those solutions because of their relevance and the fact that the community has identified them. So this graphic essentially depicts our approach, where you notice at the far left, the big circle is the foundation of our work, our infrastructure, which is centered around community engagement and capacity building. So with community driving the work that we do, that means community is informing not just what the barriers are to being able to achieve optimal health, the assets, because we don't want to be just focus on what the problems are. Communities have assets, communities have the solutions, right? Through the work that we do, our goal as practitioners should be to partner with community to advance those relevant solutions. So through community engagement and capacity building, this is the way through which we seek to mobilize resources and the partners that are involved in addressing or bringing the solutions to fruition for communities. Also, community engagement and capacity building drives changes to the physical environment and whatever those structures might be that can serve as barriers or facilitators for health. And community engagement and capacity building advances policy and systems change. And so through this fundamental component of our infrastructure and the way that we do our work, the desired outcomes and expected outcomes are that there's an increase in access to resources that promote the opportunity to achieve health and quality of life. There's increased community empowerment and capacity. There's a decrease in the prevalence of the different chronic diseases or infectious diseases that present themselves and are disproportionately impacting the communities in which we prioritize. And there's an improvement in health equity. So we have a vast array of partners, over 50 plus partners, and the intentionality of having a vast base of partners is because we are focused on the multitude of those factors that impede or facilitate communities' ability to be healthy. So if we think back to those social determinants of health, there's no way to be effective in the work if there are only partners who are focused in one particular area and one type of outcome. There's no ability to be able to partner with and partner with communities effectively. And you'll notice that communities and civic groups and the base of the residents that we work with are considered our number one partner in this work. But more importantly, again, the diversity of the partners that are involved. And so I won't talk about the different initiatives because I want to transition for the next few minutes to talk about some of our work as it pertains to the response around COVID-19. But I want to briefly highlight some of our past or existing community-driven initiatives because they're a representation of the consistent approach that we take to our work that has community engagement and empowerment at the core. So each of these initiatives that are presented here were informed by communities who identified not just barriers to them being able to achieve optimal health and quality of life, but what were relevant solutions. And so this is across different communities, whether relevant solutions was being able to have access to safe physical activity in local spaces that are culturally relevant, being able to have access to healthier food options that are quality or affordable in local convenience stores, because that is a local asset within the communities in which we're operating, or working towards other means through which children and other young people can access safe physical activity through other innovative methods, given assets that do exist in the community, or efforts through leadership and advocacy training to build capacity to effectively advocate for the necessary changes that will lead to the desired improvements within community. So each of these just being examples of initiatives that have been informed by community as relevant solutions to advance health outcomes. And then the last example that I'll provide around some initiatives would be COVID care. So this was our effort to be responsive as usual to the needs within the communities in which we operate, as well as solutions. So when COVID-19 hit, particularly in 2020, when all of the efforts were underway to try to be able to prevent the significant impact and devastation that we saw happening and continue to see happening, especially in under-resourced communities, our approach was no different than what has always been the case, which is to start at community, hear from community, and utilize that to mobilize partnerships and resources and advance relevant solutions. And so you'll see this continued thread across the work that we do where our infrastructure hasn't changed, but because the foundation of our infrastructure is community engagement and capacity building and empowering communities, that allows everything that comes from it to be a representation of what is needed by community, what are relevant solutions, and what is relevant overall. So for this COVID care initiative, there are multiple partnerships, but just to capture some of them, some of the primary ones, we worked with local apartment complex managers in some of the communities in which we operate that of course are disproportionately impacted by COVID-19 and are predominantly minority communities, so Hispanic and Latinx communities, as well as African-American communities. Those populations are represented in the areas that we work. In addition to working with local apartment complex managers, we worked with another community partner, Grow Unity Resources for Living, the Houston Health Department, and Harris County Public Health. And so these were just examples of some of the core partners that we engaged to be able to facilitate this initiative. And so some of the components of it that have really represented our overall response around COVID-19 has been registration and COVID-19 testing, being able to increase, and this was particularly last year in the fall of 2020 and then leading into this year, supporting residents' ability to register and receive COVID-19 testing, also engaging residents in surveys to be able to assess their awareness, attitudes, fears, beliefs, and knowledge as it pertains to COVID-19, and how that could lend itself to the way in which the community health workers who have led this initiative could be able to support the residents that they were speaking with. Outreach via community health workers, again, to be able to make these assessments, but more importantly, to be able to provide health education, to address some of the misinformation and the rumors and myths about COVID-19, and then to be able to connect residents to the resources that they are needing given the impact of COVID-19. And that is the most critical component of this initiative. So yes, COVID-19 testing is critical. And then eventually how we began to shift to supporting residents being able to be connected to vaccine distribution sites or other opportunities to be able to access vaccination, very critical given what's happening with the pandemic. But the base of all of this has been the importance around the wraparound resources. So the community health workers that are representing the communities that we are serving and seeking to work with, they have been the individuals that have been trained and have been driving the outreach with residents to make sure that we understand not just what the needs are, but how can we appropriately support reducing the disproportionate impact of COVID-19. And so because of our vast partnership, there are various resources available where in real time, when community health workers would connect with residents and understand what the needs are, they could direct them or connect them to the appropriate resource to alleviate in that moment in real time, how can we alleviate some of the difficulties that are being experienced and even moving forward. So one quick question, and I'm approaching, getting close to the end of my presentation, but I want to ask one quick question, particularly around the wraparound resources, is what do you think were the top wraparound resources requested by community members to address the impact of COVID-19? So you can put the letter or you can type the actual answer choice. Great. See a lot for B, housing and rental assistance. And you are absolutely correct, where the top wraparound resource was for rental and housing assistance. And so why does that matter? Again, let's go back to earlier when we were talking about the social determinants of health, the importance of making sure that what we're doing and how we're supporting community is centered around what they're identifying to be the needs and relevant solutions. So although this is in the midst of COVID-19 and trying to support testing and then eventually trying to support access to vaccination, if that's what community members are seeking to be able to do, the relevance of the work remains high because it's centered around what people are identifying as the need and the way in which we can support them getting there. One last slide related to, I didn't show, of course, all the different results from the survey and what we gathered, but this is just an example of the responses around challenges people experienced due to the COVID-19 pandemic. And so the gray represents what people identified to be a major challenge. You can see this being centered around having a job, getting the healthcare that they need, having a place to live, having transportation as some examples, which again, the reason why that this is important because the way in which we partner and seek to be able to close gaps is centered around the relevance of the work that we're doing, but more importantly, us realizing how critical the social determinants are in creating the outcomes that we're seeing. So key components of our response to COVID-19 has been the community health workers, which again, are representing the communities in which we are engaged in, right? Think back to shifting our perspective and identifying who are the experts and who needs to be driving the solutions and the work that we're doing. So community engagement support and community health worker support and engagement has been a critical component, as well as the hotline that they've utilized to be able to receive calls from residents at any point in time and connect them to the resources that are necessary. COVID-19 repository was created to be able to provide the most current health education and information as it pertained to COVID-19, to address questions and myths, and then the diverse partnership to be able to connect individuals and residents to those resources, plus different vaccine distribution sites and events. So kind of pulling all those pieces together, what does this mean for us moving forward, given the work that we do? And kind of circling back to the challenge earlier, right? So we, in the midst of the COVID-19 pandemic, we've seen the disproportionate impact in under-resourced communities and communities of color. And there's a lot of effort and interest and talk around being able to address these inequities. Well, in order to address the inequities that exist, one, we have to have a much more comprehensive perspective and be thinking about the social determinants of health. Second, we have to make sure that community engagement, community empowerment is a foundation, and it's just is a foundation to the infrastructure and the way that we approach our work, not reactive, not secondary to what it is that we are seeking to do or what we think the one side of the evidence says matters, but making sure that we pursue an infrastructure that is based on community engagement and community empowerment if we're seeking to close the gap in disparities and address the inequity. Focusing on a shift in perspective. Again, what is the evidence? Who are the experts? Let's pause ourselves to make sure that we think about that and have a much more comprehensive approach to the way in which we define those, each of these, the evidence and the experts, and how they're both are engaged in the work that we're doing. And by us doing so, that means infrastructure changes. That means there's a natural way in which inclusivity and diversity is present in the work that we do, which means the solutions are going to align accordingly and be more effective in us being able to achieve the outcomes that are desired, which the big picture is for there to be equitable outcomes. And that means that community has to be at the core and a partner in this expert base and evidence base. So that kind of covers the scope of what I wanted to present, and especially really wanted to lead us with a challenge. And that challenge, again, which is centered around our perspectives, around experts, around evidence, and what needs to be taken into consideration to achieve health equity, even in the midst of this pandemic, and the way in which our infrastructure is set up accordingly for that to happen. If we challenge our thinking in that space, that will allow us to generate very different outcomes or approaches and be much more critical about the way in which we are doing the work that we do to serve the communities that we are working with. And so I know that we are over time, but I will stop there in case there are any questions.
Yes, we actually have two questions we'll address briefly. Was COVID repository a phone bank and internet website?
Good question. So the COVID-19 repository is actually something that was built out within Box. So we just had a file management system where the interns on our team built out some of the different categories for all of the resources that were coming in around COVID-19, because as we all know, it could be rather overwhelming. There are fact sheets and different types of resources all over the place. So it's very difficult to be able to not only identify what is needed and what will be helpful, but what is also going to be most useful in translating for community or meeting what the needs are. So it was created in our Box file management system and kind of categorized with top resources that span different categories. And it continued to be updated based off of the responses and questions that we would get from residents. What is it that they were needing? What is it that they didn't understand? What were they trying to understand, to learn more about? So that constant communication with the community health workers was advancing the repository.
And then our final question from Logan, he says, good to see you. How do you address fatigue and overlap that exist in communities that are continually being targeted for health equity initiatives? How can we spread the good work across different or more spaces that have yet to be touched?
Excellent question. So thinking being able to expand the good work. One, so this fatigue is very real, but I think part of the fatigue from my perspective has also been, when I think from the community side, is the way in which we have engaged community, right? Because there have been less comprehensive approaches to the work, or it in essence has been very focused, having a narrow focus in the way in which we've engaged communities over time is created this consistent need for, duplicate efforts, repeat. Okay, now let's do this focus in a different direction. So there's these very reactive type of approaches because we have not been as comprehensive in our scope and making sure that what is relevant right now to community is what's driving the work. So then there's always this reactive approach that just becomes really redundant and can definitely lead to fatigue. So I think if we were shifting in our perspective and our approach, because we know that real and authentic community engagement is ongoing. It's not one time. It's not a response to something that's happening. If that were a shift in the way that we do our work and it were simply part of our infrastructure, then that allows us to be much more effective in where we prioritize the work that we do, how we engage community, how we're able to, I wouldn't necessarily say disseminate is relevant, but I'm hesitant to say that because sometimes I know that can be associated with, okay, here's a solution, let's spread it, right? And so that's not what I'm trying to communicate here, but the way in which the infrastructure changes allows there for to be much more continuity in the work that we do and the way in which community is driving it, right? So I think that shift in perspective will allow there to be less fatigue because it'll be much more intentional, much more inclusive, and much more upstream oriented in the work that we're doing that allows us to be less reactive.
All right, I know we're a bit over time, but thank you for addressing those questions. And thank you for delivering such a enriching and interactive message to open up the conference. We'll now move to session one, our third session for the day, for the conference, and our first session for the day.
Alrighty, everyone, we're going to go ahead and get started with session 3. My name is Haley. I will be your moderator for session 3. Let me go ahead and pull our presenters. For this session. Okay. So I will be your moderator for session 3, titled Social Justice and Health Equity. Please allow me to introduce our presenters for this session. Ronald Williams Jr. is a professor of public health and graduate coordinator in the Department of Health and Human Performance at Texas State University. He has secured $2.8 million in research funding and published over 60 peer-reviewed studies, primarily focusing on substance abuse and other health risks of adolescents and young adults. Dr. Megan McClendon completed her doctoral work at Baylor University, where she worked with rural populations of diverse backgrounds. With a focus on physical activity, Dr. McClendon participated in several community-based partnership projects that amplified the voice of these groups. She's currently working as a program specialist for Texas A&M AgriLife Extension to continue her rural work across the state of Texas. Her current project involves work with rural churches to bring health information to all concerning the emerging health issues facing Texans today. Vanessa Errizurriz is a research associate with the Latino Research Institute at the University of Texas at Austin. Dr. Errizurriz's research focuses on using a socio-ecological based approach to identify determinants of obesity that contribute to the disproportionate risk and development of obesity-related chronic disease among minority and underserved populations. She is especially interested in designing, implementing, and evaluating community-based interventions using participatory research methods and implementation science frameworks to address obesity among Latino populations. She received her PhD in health behavior and health education from the University of Texas at Austin, an MA in health psychology from Texas State University, San Marcos, and a BA in psychology from the University of Texas at San Antonio. Marisol McDaniel is a postdoctoral research fellow in the Latino Research Institute at the University of Texas at Austin. Her research interests include the built and social context of diet quality and physical activity and barriers to healthy lifestyles at the intersection of race, sexual orientation, and gender identity. She received her DRPH in community health practice and MPH from the University of Texas School of Public Health and a BA in health sciences from Rice University. So we ask that you hold all questions until the end of the session for our presenters. Also, all CHES and MCHES attendees, you will be required to fill out an evaluation. The evaluation link for session 2 and session 3 will be sent in one email at once the conference is over. So without further ado, let us welcome our first presenter, Dr. Ronald Williams.
Thank you very much. I appreciate it. I'm going to go ahead and share my screen with the PowerPoint slides. And I do want to apologize. This week, our university has decided to do some construction on our building right outside of our window here. So if if it gets too noisy or if you miss something, please just let me know. But I'm sorry about the additional noise. This project that we're working on, it was born out of actually a community partnership with a couple of local school districts. We assist them with their biannual need assessment for health risks of their youth. They participate in the youth risk behavior survey, which is of course part of the broader national initiative through the CDC. And so one of the things we've done over the last 8 years as we've assisted them with collecting their data and analyzing their data and conducting their need assessment is we've always compared our local data to the broader state and national YRBS. And so that's where the genesis of this study and a couple of other studies that we've worked on, that's kind of where it was born out of, is this partnership with our local school districts. For this particular study, we were interested in examining physical dating violence in the high school student population. Particularly, we looked at increased risks that were present for those students who identified as sexual minorities. So just to give a bit of a background, there's some literature that suggests compared to adults, adolescents are at greater risk for experiencing both physical and sexual violence from their partners in intimate relationships. The idea behind, or the theory behind there, is that it deals with a little bit of lack of maturity or lack of the development of conflict management in adolescents. They're potentially not able to handle part of the emotional circumstances in intimate relationships, thereby leading to incidences of violence. Youth are also less experienced than adults are in intimate relationships. So their vulnerability increases. There's also literature that suggests that the population of LGBT plus minority youth might be at an increased risk compared to their heterosexual peers for physical dating violence, as well as sexual dating violence. And so we wanted to look at that particular group as well in this study. So overall, our real purpose was just to examine some demographic variables using the national YRBS data. So it's the national database of 9th through 12th graders. So we wanted to see if what characteristics or covariates may help as predictors for victimization of physical dating violence. And you'll see we particularly focused one of our prediction models on those who identified as sexual minorities. And so, of course, the data is collected every 2 years. You probably are familiar with YRBS, but the data is collected every 2 years. It's been collected since I think 1999 was the first year. So it's really a good system to be able to look at longitudinal change in various health risks. Of course, the YRBS asks lots of different questions. We focus strictly on, for this particular study, only on the items that related to physical dating violence. They did have one item, and I'll show you the item in a second. So you can kind of get an idea of how they defined physical dating violence. Among the little over 8,700 students who participated in the survey, about 9.2% reported that they had experienced some form of physical dating violence. How that's operationalized in this study is, here's the question that they asked. So it's over the past 12 months, how many times did someone you were dating or going out with physically hurt you on purpose? And of course, it gives examples in the question. And so for the analysis, of course, those who reported A here, that they did not go out with anyone, those individuals were removed from the analysis. We wanted to look at those numbers of people who were in dating relationships and had reported the number of times that they had experienced some type of physical victimization. So this was our proposed model. We wanted to examine the covariates related to demographics. And so we looked at sex, grade, age, ethnicity, race, and sexual identity. We did see through our analysis that there were some statistically significant covariates here. And I'll go through each of these to give you an idea of what we found. So the first one with sex, as most literature has suggested, the female participants were at an increased likelihood of experiencing physical dating violence compared to their male counterparts. The actually interesting part here is if you look historically through YRBS data, of course, the female students are always at a higher risk than male students, but those numbers are actually getting closer than they have been in the past. So historically, you had a little over 10% of female participants, whereas males were closer to 5%. But for some reason in this 2009 data, we see this a little bit smaller of a gap. Now, we still see that sex was a significant predictor, and that female adolescents or female high school students definitely are still more at risk for being victimized through physical dating violence. But that gap isn't quite as large as it was between these two sexes. For grade was, as we kind of predicted, it was a significant covariate. It was a good predictor. And we saw that as grade increased, the percentage of students who had experienced physical dating violence also increased. I think this probably has more to do with the sheer number of students who date as they or enter intimate relationships as they increase in grade. But we did see that those in 12th grade, as a comparison, about 9.8% of 12th graders experienced physical dating violence compared to about 5.6% of 9th graders. And it was essentially each year we had a slight increase, each grade year had a slight increase in the percentage of students who experienced this victimization. One of the really interesting covariates was age. I assumed that age and grade would both have a very similar trajectory, but it really didn't appear that way. So age was also a significant predictor, but in the general population here, we saw basically what looked like a bimodal distribution. You had, starting with age 15 through 18, the risks just increased slightly every year with age. The percentage of students who were victimized increased slightly with every year. However, the actual largest risk was in those who were identified as 12 years or younger. So YRBS has a kind of a unique, they survey 9th through 12th graders, but they do have, because some of the schools that participate in this may have students who are actually age 13, 12 in those high school grades, or maybe they're in schools that don't use the traditional 9th through 12th grade format. So you do have a percentage of the participants who were age 12 years or younger, and they were significantly at a significantly higher risk of being victimized in physical dating violence when compared to the other age groups, which was, I think, interesting, and maybe speaks to some of the literature that suggests that the younger age group may not be emotionally mature enough to deal with those sort of situations in intimate relationships. So that was one of the outcomes we thought was really interesting. YRBS uses, for race and ethnicity, they use the standard census questions. And so their ethnicity question is simply, or do you identify as Hispanic or Latino, yes or no? Looking at ethnicity, there were no real significant differences in the populations that were Hispanic or Latino and those who weren't. So we didn't see any differences there. We did see some significant differences in race, particularly in the participants who identified as Black or African American. They were nearly 1.5 times more likely than white participants to experience physical dating violence. Same with those who identified as biracial or multiracial, about 1.5 times more likely to experience physical dating violence. And then the really highest risk were in the population who identified as American Indian or Native Alaskan. So I also included just the percentages of those who reported victimization in these groups. I don't have it on the screen here, but to give you the comparison of the other groups, about a little over 15% of that American Indian and Native Alaskan group reported being victimized, 9.5 in those identified as multiple races, 8.2 in Black or African American, and then white and Asian were not significant. The white group was around 7.5. The Asian participants identified, they were about 6.2% had been victimized. And the group of Native Hawaiian or other Pacific Islander, there actually wasn't enough data in that cell to make it, to even do comparisons. So that particular group, we didn't have a lot of data on. But we did see race as a significant covariate for physical dating violence. And then, of course, we also examined sexual identity as a predictor. Now, I also included the question here to give you an idea of how YRBS asks that question. So as you can see, there's kind of a limitation in how people identify whether or not they're a sexual minority. The way we identified this is, of course, gay, lesbian, bisexual, or the not sure part, we just identified that as Q. We labeled that as someone who is unsure or questioning. And so in this study and the subsequent publications that have come or coming out of it, we just identified that group as LGBTQ participants. They were significantly more likely than their heterosexual counterparts to experience physical dating violence. About 16.5% of LGBTQ participants reported victimization compared to about 7.6% of heterosexual participants. So because of this, this large difference, and because of the prior research that identified sexual minority students as having increased risk, we ran a model using only those students who identified as LGBTQ, because we wanted to see the significant demographic predictors for that particular group. Now, the model was statistically significant. However, what we found was the sex, grade, ethnicity, and race were not significant covariate predictors at all. So essentially, regardless of any of these demographic predictors, if a student identified as LGBTQ or identified as a sexual minority, then they were at risk regardless of the other demographic characteristics that they may have. And so we think that that's a very significant finding for those who work in school health or work in adolescent violence prevention, because we know that this particular group of sexual minority students are at significantly higher risk for violence victimization. What we did find, the one significant predictor was age. And it followed basically the same pattern in this group as it did with the larger group, which is that those who identified as 12 or younger were at a much higher risk than the other age groups. So again, regardless of sexual identity, those who were young and participating or active in intimate relationships were at a much higher risk of being victimized physical dating violence. So just to sum it up, we did find that physical dating violence victimization is higher in adolescents who were female, who identified as LGBTQ, who were Black or African American, or American Indian or Native Alaskan or multiracial. And also we saw that risk increases as you move through grade levels. However, I think the bigger finding really is here that both in the group, in the participant group overall, and in the specifically sexual minority youth subpopulation, there's a significantly increased risk for those who start dating at age 12 or younger, those who enter intimate relationships at this very young age are at a very much higher risk of victimization for physical dating violence. And we hope that a study like this and some of the other stuff that we're working on can be useful to school and public health educators as they're identifying at-risk groups and high-risk groups for the development and implementation of prevention programs that are targeted to reducing overall violence victimization. And then I just have my references here. And I don't know the setup. Are we taking questions now, or are we going to take them at the end of the session?
So we'll take questions at the end of the session. Thank you, Dr. Williams. Let us welcome our second presenter of the session, Dr. McClendon.
Hello, everyone. All right, hello, everyone. It's nice to be virtually present with all of you. I'm excited to be discussing rural America and how we can empower this disparaged group through public health education. So today I'll be introducing rural America and some of the challenges that are being faced by people living in rural areas. I'll highlight current efforts to emphasize gaps in understanding so that opportunities can be discussed. Discussion of these opportunities is essential as we try to decrease disparity and increase equity. So much of our news coverage focuses on big city issues and living. Headlines often include comparisons of the nation's biggest cities concerning safety, crime, and quality of life. Much of the current research is conducted in urban and suburban areas, creating disparities within rural communities concerning information, understanding, and intervention. Because of these facts, many may not realize that over half of all counties in the United States are classified as rural. It is important that we understand the rural parts of this country because they are vastly different from urban areas. Let's begin by answering the question, what does rural mean? A Google search of the term reveals the following definition: of or relating to county, country, people, or life, or agricultural. So what does that mean? The United States Department of Agriculture created rural-urban continuum codes that form a classification scheme to categorize counties based on their population size, urbanization, and adjacency to metropolitan areas. Unfortunately, these codes were last updated in 2013 and do not accurately represent many rural areas. This leaves us with an inaccurate depiction of rural America. Additionally, this schematic representation of geographical areas does not depict the intricacies of everyday life or further our understanding of the disparities faced in rural America. Lee and colleagues explored these intricacies and note that rural decline is occurring due to an inability of rural areas to adapt and innovate to external changes. They note that rural areas have strong community ties and that residents in these communities are the factor that can create sustainability. Rural culture, decline, and sustainability are important components for us to understand as we move toward discussion of public health education, because we must first meet basic needs before we can move toward self-actualization. With sustainability in mind, it is important for us to consider the entire social ecological model and how this can be utilized to empower rural America through public health education. For the individual, we need to know their knowledge and attitude toward public health education. Often this information is unknown and education interventions are unsuccessful as researchers attempt to utilize theories and materials created for urban communities. For interpersonal, rural decline has created the need for subsequent generations to seek education and employment outside of their hometowns. This has led to rural outmigration that has crippled many small towns across the nation. Outmigration within the rural context means that these areas are suffering a loss of community and a loss of human capital. For organizational, we find that there is either a lack of institutions and or a disconnect between rural areas and their nearest urban and suburban areas. This creates difficulties when trying to increase or enhance public health education. For community, we see that rural areas have higher rates of poverty, diabetes, and obesity, increasing the need for public health education. We also see that communities are the sustaining factor in rural areas, showing a potential to utilize community-based participatory research to better understand rural communities. For public health policy, it should be noted that rural areas often feel excluded from policy creation, which leads to a strained relationship with government at all levels. So previous efforts. Now that we've explored rurality from a contextual standpoint and then explored underlying needs and issues within the social ecological framework, let's look at efforts that have existed within these parameters. Researchers have recognized that rural communities are unique and need different approaches and solutions. Previous efforts include telehealth, qualitative investigations, and secondary data analysis. For telehealth, efforts to increase the utilization of telehealth within rural areas has been a noble venture. However, reports show that there are still many unresolved issues, including broadband infrastructure, patient volume, technology needs, and state licensing. Additionally, there is a need to explore the affective impact of telehealth on long-term outcomes within rural populations, because rural areas thrive on community and personal interaction and may not be as receptive to online medical services. For secondary data analysis, a recent study that examined environmental influences on adult physical activity represents the differences between urban and rural areas. This study revealed that not only are rural areas different from urban areas, but that there is a continuum that leads into different degrees of rurality. For example, Natural environment was negatively associated with all rural counties, where recreation environment was only a factor in some of the most rural counties. This highlights the uniqueness of rural counties and a need to tailor efforts. Qualitative efforts have been conducted to elucidate these needs and differences between rural areas and to highlight many levels of the social ecological model. In a comparative case study, 3 rural counties were analyzed using stakeholder interviews, intercept interviews, and researcher observations. Findings include differences in culture, human, and organizational capacity. Cultural differences involved attitudes and beliefs as to type of physical activity. Rural areas that are more active tend to have more options for being physically active. Next, the human capital in these rural communities included leaders within school administration, church leaders, medical professionals, and elected officials. More disparities were seen in communities where these individuals lived far outside of town. This reiterates the fact that community is so important to the functionality of our rural areas. Finally, organizational capacity involved collaboration across organizations to overcome lack of capacity. Collaboration occurred across the county and included economic development plans that would be beneficial for all. This could be the key to overcoming the disparities faced with loss of community. These previous efforts reveal the importance of exploratory work that is guided by each rural area. The largest offender to effective rural health education is lack of understanding. Future efforts should consider community asset building, as community is important within rural communities. Asset building will pool resources, but could also help reduce outmigration seen in rural areas. There's also a continued need for qualitative works that seek to understand without bias or outside influence. We often fail to fully comprehend what this means in a practical sense. I have a few quick examples to elucidate my points. Both examples have a spiritual and religious focus, as research shows that rural areas have a high affinity for this dimension of health. The first example, the Well Church Initiative, is a program that is seeking to partner with churches, faith-based organizations, places of worship, nonprofit organizations, healthcare, and statewide agencies to provide health education to rural areas. Within this program, health surveys are capturing individual level health and understanding, and extension agents within the community and other partners have been recruited to build community capacity. This allows for asset building within the communities, includes quantitative and qualitative data collection that will be distributed to health education specialists and the churches. That then allows for health education to be tailored to the needs of the specific rural communities. Partnership with churches requires us as researchers to build trusted relationships with these churches that is tangible to the rest of the community. This type of trusted relationship helps bridge the gap created by distrust of public policy often felt by rural areas. Next, the Excite grant seeks to ask participants about their perspective of the COVID-19 vaccination. This survey can be taken by all and has a specific question concerning spiritual and religious beliefs. Many in the media and political world assume that rural individuals do not want the vaccine because of lack of communication or because of governmental distrust. This survey for this grant removes these biases by allowing open-ended responses that will reveal the truth. For example, those who identify as spiritual and or religious may refuse vaccination for spiritual or religious reasons. Vaccine education tailored to combat distrust would not work among this group. This approach is powerful as it will help tailor vaccine health education that is accurately based on the held beliefs and understanding of people within rural areas. Health education built on false assumptions would not be impactful. Health education built on beliefs will be much more powerful. So, how do we empower rural America through health education? We have to begin by understanding the disparities and strengths of rural America. We then have to listen to understand their attitudes, understandings, and their needs. Only then can we create health education and empower these communities to lead healthier lives. Thank you.
Thank you, Megan. Next up, we have Dr. Erisuris and Dr. McDaniel. I think you're muted.
All right. Hi.
Hello.
Can you hear me? Okay, great. And it's a full slide presentation on the, just want to make sure I'm sharing the right screen, guys. Okay, good morning, everyone. Before we begin, Marisol and I would like to say thank you to TSOPHE and Haley Delgado for inviting us to be a part of today's panel. And thank you to all of you for attending our presentation today, which is entitled Identifying Social Determinants of Food Insecurity Among Texas College Students During the COVID-19 Pandemic, a Matter of Social Justice. So in this presentation, we'll briefly review the following: the prevalence of food insecurity among college students prior to COVID-19 and its related consequences. We'll review findings related to food insecurity from our COVID-19 College Student Experiences Survey, and specifically our work identifying social determinants of food insecurity. And then we'll discuss the social justice implications of our findings. So to begin, food insecurity is a lack of consistent access to enough food for an active, healthy life. And prior to the COVID-19 pandemic, research found that food insecurity rates among US college students ranged from 20 to 50%, with over 34% of students estimated to be food insecure in Texas. Food insecurity rates among college students are considerably higher than the 12% rate estimated for the entire US population. And so this is very concerning because food insecurity is associated with a variety of adverse consequences. Those who are food insecure tend to have lower diet quality, are more likely to experience eating disorders, have poor mental health outcomes, and exhibit lower academic performance. And so we've talked about social determinants of health a lot today. And these social determinants of health, as the keynote speaker mentioned earlier, are conditions in environments where people live, work, play, etc. And all of these play a big role in food insecurity disparities. And there are 5 key areas of social determinants of health, as you can see in the graphic on the screen. And factors in each of these areas can contribute to food insecurity among college students. So in general, food insecurity is linked to poverty and low education levels, as well as delayed healthcare access. And then food insecure college students are more likely to receive financial aid and be low income, employed, and housing insecure. And so we know that the COVID-19 pandemic led to the closure of higher education institutions all across the US. For college students in Texas, these school closures negatively impacted all 5 key areas of social determinants of health. And it's likely that food insecurity was exacerbated by some of these changes to social determinants of health. So for instance, and I'll just go through a few of these, with regard to the neighborhood and built environment, you had dining halls, restaurants, and food pantries close, limiting students' access to food on or around campus. Social distancing guidelines also impacted the social and community context by limiting social interactions, including at meetings and events where students are provided free food, or at least they can access free food. And then finally, students may have lost employment, including on-campus or work-study positions, and this impacted economic stability and negatively affected students' ability to purchase healthy foods, right? So those are just some examples of the impact of COVID-19 on these social determinants of food insecurity. And now I'm going to turn it over to my co-presenter, Dr. McDaniel.
Hi, good morning, everyone. So to help and identify and address the emerging food-related needs of Texas college students resulting from this historic pandemic, we conducted a study that aimed to, number one, examine food insecurity prevalence of college students pre and post-pandemic declaration, and two, identify social determinants related to food insecurity among Texas college students during the pandemic. Between June and August 2020, an online survey was distributed to college students across the state of Texas. To be eligible, students had to be at least 18 years old and currently enrolled in a Texas higher education institution, be it part-time, full-time, undergrad, grad, community college, etc. 1,144 students consented to participate in this survey, with 628 completing the survey. A majority of respondents were female, non-Latino white, US born, and lower income, with an average of 28.4 years old. To assess food insecurity pre and post-pandemic declaration, students were asked questions related to whether they ran out of food and didn't have money to get more, and their ability to afford balanced meals. If they reported often or sometimes true to either question, they were considered food insecure. Students also reported the pandemic's impact on various social determinants of health, including their employment status, if they had to move because of the pandemic, like moving back home, if their campus closed, were able to pay rent or not able to pay rent, avoided seeing a physician for a health problem, and if their institution provided sufficient emotional well-being and medical resources. Food insecurity prevalence increased by almost 10% pre to post-pandemic declaration. Of note, social determinants such as household income were associated with food insecurity. Students whose family's household income was greater than the Texas median income, which we kind of calculate as approximately $60,000 a year, were over 30% less likely to be food insecure while in college. Students who've moved back with their families were less likely to be food insecure as well. Housing insecurity is associated with food insecurity, very highly associated actually. Students are worrying about keeping a roof over their heads as well as being able to eat, in addition to completing their studies. One social determinant associated with food security rather than food insecurity is the perception of colleges providing adequate resources, and for this specific measure, it was medical resources. Food insecurity is not only associated with health outcomes, but can have implications for being successful in school and in turn, social mobility. College campuses should be cognizant of financial conditions that may place students at risk for food insecurity. Collecting university-wide data about food insecurity and related social determinants will better position institutions of higher education to advocate for policy changes at the state and federal level regarding college affordability for all students. Higher education institutions can also support students by providing direct resources such as food pantries and food hubs on campus, where students can pay on a sliding scale. There are other ideas around the nation of what people can do, but that's something that we've kind of heard here in Austin, even for the community members here in Austin. There is a proposal to provide like a sliding scale food hubs for areas that are known to be most food insecure. So why can't we have that on college campuses as well? One example of ways you can make a change on your campus, as I mentioned, food pantries, is to support food pantries, including grassroots food pantries such as La Tiendita, that serves the students of Latino and Black Studies at UT Austin. Dr. Eddie Sudis and I are part of a team interested in providing fresh produce to La Tiendita patrons, because right now we just kind of have just shelf goods and everything's on a shelf. After networking and many conversations with student support staff and leadership across campus, we found other food pantries on campus that are also interested in providing fresh produce. And we decided as a collective that the best step moving forward is to partner with the food bank, which our local partner is the Central Texas Food Bank here in Austin. However, many food banks, including the Central Texas Food Bank, can only partner directly with 501c3s, and universities are not 501c3s due to USDA regulation. So therefore, in order to partner with the food bank, we have to partner with the nonprofit, kind of be like our middleman in a way, and which for us was naturally the UT Foundation, University of Texas Foundation. And during this journey, we have connected with staff, and we are now also the members of 40 Acres Food Alliance. So even creating organizations or networks like that on campus can start with moving towards addressing food insecurity on campus. We are excited to soon be able to remove the access barrier for students as far as having access to fresh produce and address food insecurity on campus. Thank you.
Thank you. So we're going to go ahead and.
Oh, one more slide.
Sorry.
No problem. So if you'd like to know more about this study or our COVID-19 College Student Experiences Survey, please feel free to contact me or Marisol by email. There are also a couple of Latin Experts podcast episodes dedicated to our survey findings that you can listen to. And then we're also currently conducting a second wave of data collection to examine the current state of health and well-being among Texas college students. We welcome you to take our survey and share your experiences related to COVID-19 and its aftermath. So we'll go ahead and place that link to the survey in the chat. And then we just want to say thank you again for your attention to this presentation.
Thank you to all of you. So we're going to go ahead and open the floor up for questions. We have around 10 minutes for questions. So if you have a question, please feel free to drop it in the chat or in the Q&A feature. There is one question that's open, I believe, directed to Megan. What qualitative data or comments have been realized by researchers conducting rural surveys?
So one of the things that has been really interesting is that, and we've seen it happen across the country, I feel, within the last year or so, but you only know what you know. And so as a person who grew up in rural America, I was fully aware of the disparities faced, but we went into an area and I went with a researcher who was not familiar with rural America. And it's always interesting to see someone who doesn't fully understand walk into a situation like that. And so someone who from an urban area walks into a rural America and they're just completely shocked by the fact that these are normal people who are trying their best to live their life, and there are no biases, there are no weird things happening in rural America that just aren't happening in urban areas. And so it was interesting to me to watch the researcher instead of the people in the rural community, because it was just eye-opening. And I feel that was so eye-opening for me. It's just we have to share the information on the fact that rural communities just need to be heard. We need a little understanding, which honestly, when we talk about disparities and equity, we're trying to get the word out about all of these different populations. And so for me, it wasn't anything new because I'm from a rural area. And so for me, the biggest piece was watching as people who aren't from the rural area trying to understand, and then having their eyes opened. That's really the biggest piece, is just spreading the understanding, which again, I feel is what we're all trying to do within our own little pockets. I mean, you saw 3 different presentations today who we're all looking at 3 different populations. And so understanding is just the biggest key.
Thank you, Megan. We also have another question for Marisol and Vanessa. You mentioned that students who moved back with their parents were 60% less likely to be food insecure. In other words, it could be framed as a highly successful intervention. Is this something that should be further explored? With limited available resources, should we be looking or investing in food pantries or focusing on cultural changes so that people move back in with their parents?
That's an interesting take. And I guess what I see, I guess we don't know why that is. So one thing I can think of is, especially for families that have a lot of younger siblings, and if they are low income, they may be on SNAP. And they do not get SNAP when they're in college. Actually, it's not automatically transferred to college. They need to apply as an individual. And so that may be something that needs to be explored further to see if maybe there's a relationship with the family receiving SNAP and becoming more food secure when you're going back home. And there could be other things of just feeling a perception of food. And honestly, people cooking for you could also be nice, and could help with feeling more food secure as well.
Do you have anything to add, Vanessa?
The only thing I'd like to add is that a lot of students do, attend college, not necessarily in their hometown. And there are mixed findings with regard to the effectiveness of virtual learning. And so I think while it is a very intriguing question and something that should be looked into, I think we would also have to balance, potentially the benefits of living at home and feeling more food secure with, education and values, and the actual, quality of education that they would receive in online learning. So it's kind of I don't know, I could see that being a mixed bag, but it's certainly an interesting question.
Thank you. Do we have any other questions? No? All righty. Well, with that, I want to thank all of our panelists. Again, we're going to go ahead and transition over to session 4 right now. And just keep an eye out in your email for the evaluation link for this session and yesterday's session 2. So again, thank you everyone for joining us for this session.
Thank you.
Thank you.
Okay, thank you.
Alrighty, everyone, we're gonna go ahead and get started. I am going to go ahead and hand it over to Eva, who will be your moderator for this session. Let's see, let me make sure she's added as a panelist. Give me 1 second. Hi, Eva.
Hello, everyone. Good morning. I feel like it's afternoon, but no, it's still 11 here in Austin. My name is Eva, and I am part of the Program Planning Committee and also part of the TSOPHE board as the graduate student representative. I'll be your moderator for session 4, and the topic of this session is health in a pandemic setting. So before starting, please allow me to introduce our presenters for this session. So first is Joshua Judkin, who is an experienced epidemiologist with a strategic and outcomes-oriented mindset. Judkin has been awarded both a Fulbright Research Grant and the Archer Fellowship to continue his research, developing new national healthcare policies and strategies aimed at disease prevention in Colombia. He has served as a researcher at internationally renowned research institutions such as the National Institutes of Health in the United States and the Myers JDC Brookdale Institute in Israel. Judkin has conducted both field and clinical research in rural communities in places such as Tamil Nadu, India, and Chihuahua, Mexico, as well as hospital systems in Texas in the United States. He has presented at major conferences like the American Public Health Association, APHA, and currently serves as the Texas Society for Public Health Education, TSOPHE Executive Board. Next, we have Kathleen Matthews, who is a rising junior at Rice University, where she studies health sciences and social policy analysis. Kathleen has been passionate about public health since high school and has worked at clinics, research organizations, and philanthropic foundations. Currently, Kathleen serves as a research intern for the kinesiology department at Rice University and as a congregational engagement intern for the Episcopal Health Foundation. Next, we have Cassandra Cassie S. Diep, who is an assistant teaching professor in the kinesiology department at Rice University. Dr. Diep joined the Rice faculty in 2017 and currently teaches principles of public and community health, disparities in health in America, and the health sciences courses. She also serves as a major advisor for health sciences. Dr. Diep also earned her Bachelor's of Arts in Kinesiology from Rice University and her Master of Science and Doctor of Philosophy in Health Education from Texas A&M University. She completed a postdoctoral fellowship in behavioral nutrition at the Children's Nutrition Research Center at Baylor College of Medicine, where she led a series of studies on the role of acculturation in Asian American children's diet, physical activity, and health outcomes. Afterwards, she became an assistant professor in the Department of Health Disparities Research at the University of Texas MD Anderson Cancer Center. She was part of the Center of Community Engaged Translational Research, where she abridged her research expertise with community partnerships to develop, implement, and evaluate interventions to reduce obesity and cancer disparities in community and population-based settings. Dr. Diep's overall program of research focuses on understanding, preventing, and intervening on determinants of health behaviors and conditions in at-risk populations. The majority of her work has focused on health disparities in diet and physical activity behaviors, childhood obesity, prevention and intervention, Asian American health disparities, and behavioral theory and health behaviors. Next is Taylor Levi, who is currently employed as a nutrition coordinator and registered dietitian for the Child Nutrition Services Department with Leander Independent School District. Her job duties consist of student engagement and outreach, menu modifications, and supervision of food service department staff. She received her BS in nutrition from Texas State University, a registered dietitian license from Oregon State University, and a Master of Science in Health Education and Promotion from Texas State University. While pursuing her master's degree at Texas State, Taylor assisted local school districts with implementing the Youth Risk Behavioral Surveillance Project and completed a thesis exploring COVID-19's impact, how COVID-19 impacts food insecurity and healthy dietary behaviors. And finally, we have Dr. Mary Odom, who is an assistant professor of public health in the Department of Health and Human Performance at Texas State University. Her research focuses on understanding socio-ecological influences on childhood obesity and chronic health conditions, and implementing community-based interventions targeting health behavior change, primary nutrition, to reduce individual and familial risk of obesity and chronic diseases. Dr. Odom serves as the lead faculty advisor for the Delta Chi chapter of Eta Sigma Gamma. Those are our excellent presenters for today's session. And we ask that you hold all your questions until the end of the session, or rather you can start putting your questions in the Q&A function, but we won't address them until after everybody has presented. If you are interested in getting CHES or MCHES credits, like last session, like Haley said last session, we'll send you a separate email with the link for this session. All right, well, let us welcome our first presenter, Joshua Yudkin. Yeah.
Thanks, Eva. It's really exciting to be here with everybody. I think whoever's sharing their screen though has to stop sharing so that I can share my presentation.
Oh, that's me. Sorry. There you go,
No worries.
Josh.
Cool, thank you. Okay, so good morning, everybody. I'm really excited to be here to talk about a really important topic. The title of my presentation is COVID-19's impact on the police legitimacy. It's a case study. And I think just as a couple initial notes, something to keep in mind is I'm going to be focusing on the situation in Israel last year because that's where I actually happened to be based when the pandemic broke out. And so I was very much in tune with what was happening there. But I think one of the things you'll see, especially as we get toward the end of the presentation, is that the lessons and the applications can be applied pretty much most countries around the world. So to start off with some background information, police violence and brutality is a documented issue. Just to kind of stick within the TSOPHE realm, TSOPHE had a statement where they declared law enforcement violence and police brutality is a threat to the community and public health. Similarly, the American Public Health Association declared that physical and physiological violence that is structurally mediated by the system of law enforcement results in death, injuries, trauma, and stress that disproportionately affects marginalized populations. And I think equally, if not more importantly, this sentiment and these findings have been echoed by many different international organizations. But I want to quote the UN, the United Nations, because they actually talked about it in the context of COVID, which is obviously the topic of my presentation. And they specifically said that since the outbreak of the COVID-19 pandemic, there has been numerous reports of security forces employing excessive and often indiscriminate violence, resulting in unlawful deaths, injury, and psychological trauma, as well as arbitrary detentions in order to enforce emergency measures for the protection of public health, such as bans on assemblies, lockdowns, and curfews. And so I think a couple key messages here is that in the context of COVID or outside of the context of COVID, we see that police violence and brutality is a big issue in different countries. It's been motivated by different things. There's been studies that have showed, racism, and it's racially motivated. There's other places there's political protests and politically motivated. But I think what's really important here is that while there's diverse causes and diverse manifestations of it, is that this is an issue, and it's been echoed in many different contexts. The second important kind of public health concept that I just want to make sure we all have a clear understanding definition-wise before I keep going is this idea of surveillance. So I guess, my background is epidemiology. I'm finishing my PhD in epidemiology at UT Health. And one of the key tenets of epidemiology is there's two parts to the field. One is the active surveillance, monitoring, the quantification of issues. And the second part is the application to policy. So surveillance is very much in that first piece, where it's how are we gathering the evidence so we can employ it and apply it to public health and policy changes. So just a couple definitions that I felt like were important. One is that surveillance is, quote, the ongoing systematic collection, analysis, and interpretation of health-related data, essential to the planning, implementation, and evaluation of public health practice. That's also the definition the CDC employs here in the US. And then I just felt like in terms of the impact or utility of it, there was a great chapter in a book, actually. And it said, public health surveillance provides the scientific and factual database essential to inform decisions making and appropriate public health action. The key objective of surveillance is to provide information to guide interventions. And there's this famous quote that I like that says, what gets measured gets done. And so I think the key piece here and what we're going to see is that measurement is really key in the work that we're doing. So like I said, I was based in Israel. It's in the Middle East. It's a very small country that if you look on the left, you can barely see in purple, in the middle, just above Egypt. And on the right, you can kind of see the geography of. In terms of political structure, just because this is a political issue in some ways, is that, Israel has a parliamentary democracy, so it's a little different than the American democracy. So if you're familiar with government, it's more similar to that of England or Italy. And they have 120 members in the Knesset, which is kind of like their Congress. When we look at where the Israeli police falls, before we get there, just some basic information so we can kind of understand what's the population of interest here. It's roughly 9 million people. It's roughly 0.1% of the world's population. When we look at city population, so kind of their biggest urban environments, they're all under 1 million people. And in terms of ethnicities, it's roughly 3/4 Jewish, 20% Arab, and 4% others. And something that's important to note is that Arab is more of a geographic identity. A lot of people often, when talking about the Middle East, get confused, or they'll think that Arab is synonymous with Muslim, but Arab is actually a heterogeneous population. So you're going to have Christians, Muslims, and then Druze kind of typically fall within that category. So the Israeli police fall under the jurisdiction of the Ministry of Public Security. Across the entire country, there's roughly 35,000 people who are police officers, and it's the sole civilian law enforcement agency in Israel. It's divided into regional districts as well as operational units. And previous research, although be it from quite a bit ago, had showed that there were low levels of trust and satisfaction with the police. So I think just a couple key takeaways here is to think about. One, when we think about the US context, a lot of us kind of our limited interaction with the police might be a speeding ticket or a seatbelt. The police in Israel traditionally have been less focused on kind of the day-to-day seatbelt and speeding, and more focused on kind of terrorist threats and security issues. And so what we're going to see here is that the pandemic actually was a very new interaction between the public and police, where the police don't typically interact on day-to-day issues for the population. And so given the fact that they had so many day-to-day responsibilities, it wasn't always what we're going to see is the changing and the complicated iterative policies around COVID, but it was also kind of a new frontier in which they were interacting with the public. So if we look kind of just a couple key things I want to share was that between March and May, there was over 15 different iterative regulations that were formed. This could have been where you could have 100 people gathering, 50 people gathering, 10 people gathering, 50 people gathering, things like that. It was also things like you have to be within, 500 feet of your house, 250 feet of your house, 100 meters of your house kind of thing. And so, one of the things that we'll see is that for police officers to disseminate and translate the changing policies from Congress was challenging. And for the population to know what the policies were challenging, and then to have the interaction between the police and the public was also challenging there. Secondly, like I mentioned, the Israeli police were tasked with enforcing new civil policies. And so this was very much a new frontier in many ways for their interactions with the public. The pandemic created new interaction points. So that could be things like wearing masks, distances. And I think, one of the things that we often don't talk about is mental health is a documented issue for everybody in general, but I think especially during the pandemic, it was exacerbated. And so there was higher levels of stress in police officers, there's higher levels of stress in the general public. And so in an already heightened kind of tense area, we're seeing these issues, these policies becoming complicated because of just personal health of everyone involved in the situation. And then lastly, of course, the Israeli police had more visibility to the public because of it. In Israel, there was some actually amazing innovation that happened that was disseminated regarding COVID. So one of the things you can see here is kind of like it's a completely like foolproof booth in which they were running COVID testing, which I think was really amazing. And so it gave people a level of comfort. And then in terms of the relationship with the police, there were many successes and there were many great relationships. And I think there's great examples of showing how the police and society work together to be able to carry on day-to-day civic interactions, despite the fact we're in the middle of a pandemic. This is in Tel Aviv, right outside the city hall and Rabin Square. And it was a protest. It was a political protest against the government. And you'll see, there's kind of where the camera's coming from. I mean, there are thousands of people in the square. And if you look very carefully, there's little squares about 2 meters apart. And so they kind of gave everyone in the protest, they said, get there early, and everyone had their own box and square. And so it was done in a really beautiful way where it was COVID friendly, or it was COVID safe, I guess maybe is the better way of saying it. And people could participate in civic actions, and it was coordinated, and there was great relationships that happened during COVID. So when we look at the literature around COVID, a lot of the literature around COVID and pandemics places it in the same category as a natural disaster. Because in general, it places novel demands on police and on society, as well as governments and healthcare systems. So just in terms of locating pandemics in literature, typically pandemics are located within that idea of natural disasters. And previous studies have showed in emergency situations that these situations often can create negative interactions between the public and the police, and the level of trust between the public and the police. COVID-19 related stressors have also increased mental health problems. We talked about that. And that's both in society as well as in the police and general society. So kind of when I come out, so when we started to kind of think about this research and looking at how the relationship changed, it was interesting because in general, in my mind, I think it could have been either direction. There wasn't necessarily a directional hypothesis. And when we looked kind of to see what was out there in the literature, there was only one study. And interestingly, the study kind of focused on I guess kind of like the white Ashkenazic Jew, the kind of more like middle upper class, traditionally socioeconomically in Israel. And it didn't really include anything focused on vulnerable populations. So that could include Mizrahi, which are kind of Jews that come from Arab lands. It doesn't include the Arab population. It doesn't include immigrants, refugees, etc. And so it was kind of one of those interesting things that said, well, we really don't know what happened in this relationship, but I'm not sure that the existing study is really comprehensive in showing it. Simultaneously, there were a lot of stories on the media, kind of similar how you'd see in other countries in the US, et cetera, that showed that police misconduct, was tied to using it differentially against different target groups for civil offenses. And it included people of all ranks in the police, and it showed that these allegations were against people of diverse, vulnerable populations regarding age, ability, race, ethnicity, et cetera. And of course, like kind of any country, shouldn't say any country, but like if you look in the US, right, we have news channels on the right, we have news channels on the left, and they're going to cover stories differently. And so the stories were getting covered very differently. And I think one of the things that was noticed was there simply wasn't scientific, rigorous, unbiased information out there as to how this was affecting relationships, how this was affecting dynamics. So our conclusion was, we simply don't know. And like I said, it could go either direction. So we might be sitting here being like, okay, this is all really interesting, but why does this matter in a public health context? So one, police brutality has been, like we talked about initially, labeled as a public health issue by many organizations, especially leading public health organizations. And then if we kind of look from that more transdisciplinary collaborative perspective, police brutality and violence very much falls kind of in the realm within political science, saying that trust in the police is a critical indicator of weak societies. Trust in police is a risk factor for adverse health outcomes, including stress, anxiety, hypertension, diabetes, asthma, and is associated mortality due to these complications of these comorbidities. It can also lead to micro and macro aggressions resulting from police language that escalates in civilian interactions and it can lead to direct and measurable adverse health outcomes through violent confrontations that result in injury or death. And so therefore, when we look at it on a societal level, on an individual level, on a health perspective, from a political perspective, police brutality is like a really important thing that we should be measuring and we should be understanding. So the short answer is, at this point, it's very hard to know what to make of this. And the lack of scientific evidence is really a call to action for the entire field, both those focusing on Israel, but I think in many countries, because you're going to see this trend across the world, really, to say that we need to be doing surveillance on this issue and we need to understand how this relationship has changed. And then secondly, of course, is there's a need for greater screening, outreach, and better access to healthcare, especially mental health healthcare for everyone, both police and citizens alike. When we're thinking about what's our role in this situation as public health practitioners, obviously we need to identify the systemic determinants and the health consequences of distrust in the police and develop and evaluate solutions to address this distrust. And why, of course, the apolitical, transdisciplinary, and rigorous scientific framework that informs public health perspectives positions us to be able to investigate a controversial topic that has such significant impact in terms of society and overall health. So for Israel, we were recommending 4 steps to go forward. One was to explore the impact of public health emergencies, such as the COVID pandemic, on police and police-public interactions. 2 is to clarify the current and dynamic responsibilities of the police. Obviously, within 60 days, the responsibility is changing 15 times. That makes a very hard implementation challenge and reality for everyone on the ground. 3, we need to be conducting ongoing surveillance on the Israeli public's distrust of the Israeli police using rigorous research. 4, we need to report regularly police misconduct in a way that's transparent. And 5, it may or may not be applicable because we really don't know how it impacted relationships, but assuming there was mistrust and that was magnified, we need to develop strategies to improve the Israeli public's perception and trust in the police. There's great articles out there from organizations like the American Public Health Association that really talk about how to do it. And I think our findings really much match those approaches that says we need to be using upstream, community-based, community-led frameworks to encourage and align the efforts of public health professionals in reducing the distrust and advancing the relationship between the public and police. And so again, while this was a case study really on the other side of the world, I think the lessons can be applied in pretty much almost every country, saying that surveillance is critical in terms of making public health decisions. Police violence and brutality is a critical indicator both for society and political decisions in terms of health outcomes for society, and that we have an obligation and an opportunity really to make sure we're doing the best job possible at conducting that surveillance and using it to inform decisions. So thank you very much for the opportunity to present.
Thank you, Josh, for this incredible presentation. If you have any questions for Josh, please put it in the Q&A. Again, we will go back to those questions once everybody has presented. So let us welcome our second presenters of the session, Kathleen Matthews and Dr. Cassandra Diep.
Good morning. I'll go ahead and share my screen. All right. Good morning, everyone. My name is Kathleen Matthews, and today with Dr. Cassandra Diep, we'll be presenting our findings on food insecurity and dietary behaviors among Houston college students during the COVID-19 pandemic. In some ways, our study does share similarities with the food insecurity study that was shared in the previous session. So today we'll aim to elaborate on some of those results as well as share some of our own findings. Okay, so to introduce this topic, I'll reference some previous work that's been done in this field. So we know that the COVID-19 pandemic has impacted nutrition nationwide. It's led to new barriers in accessing food, including lockdowns, reduced family incomes, shifts in consumer purchasing patterns, and really has made it more difficult for people to make good nutritional decisions. Additionally, college students may be at particular risk when it comes to poor nutrition generally. This has to do with very easy access to junk food, increased levels of stress, students having to make nutritional decisions, oftentimes for the first time in their life, on their own. Really all of this combined leads to college students making poor nutritional decisions. There is conflicting research on the impact of the pandemic on nutrition among college students. We specifically looked at food security status and dietary behaviors, and we'll get into some of this literature in the next couple of slides. So in terms of food security, food insecurity is associated with both poor mental and physical health outcomes, and the pandemic has led to higher rates of food insecurity. So the graph on the right pulls data from a Morales et al. Article, which demonstrates a 13% increase in food insecure American households between March 2020 and April 2020. And other research has demonstrated this as well. A Gunderson et al. Article predicted an increase of 17 million food insecure Americans between 2018 and when their study was published in 2020. So we really have seen a huge spike in food insecurity in the US. It has been established that college students are at particular risk when it comes to food insecurity during the pandemic. However, there are mixed results based on disparities that lead to higher rates of food insecurity. So students from racial and ethnic minorities, students who experienced a job change, students with children, students with parents with lower education levels, and younger students were all at higher risk for lower food security status. However, there are mixed results based on the impacts of gender, obesity, and living status. There are also mixed results on the impact of the COVID-19 pandemic on dietary behaviors. Some studies have demonstrated that people began consuming more sweet and salty snacks, and that obese participants were especially likely to negatively impact their diets. However, other research has actually found positive changes to people's diets, including eating more fruits and vegetables and eating more home-cooked meals. However, almost all this research has been conducted abroad, and there are no published studies so far on dietary changes among college students during the pandemic. So this is definitely a gap in the literature that we aim to fill with our study. So the purpose of our study was to assess the impact of the COVID-19 pandemic on college students' nutrition. We looked at food security status and dietary behaviors, and we were specifically interested in disparities and determinants of poor nutrition. I've already mentioned some of the reasons that college students are at increased risk for poor nutrition. However, we hypothesized that the pandemic has worsened students' nutritional intakes because they were forced to move home, which meant that they had to adjust to new social and environmental situations, and they likely were contending with higher levels of stress as well as worsened financial burdens. So we used data from the COVID-19 stress, physical activity, and nutrition effects on students survey. This survey was open for all of November 2020, and it was administered by the Rice Kinesiology Department. Our participants included students who were enrolled in a college or university in the Houston area between the ages of 18 and 25, and we ended with a sample of 140 participants. Our survey included 63 items over 5 sections, including demographics, physical activity, diet, food security, and stress. For this study, we specifically looked at food security, diet, and demographic sections. We used descriptive statistics to look at demographics and inferential statistics, including chi-square tests, t-tests, and ANOVAs to look at dietary behaviors and food security status. So our study was administered through Qualtrics, and it was distributed through Canvas course pages, as well as through student and faculty listservs, and students were entered into a raffle to win one of 5 $20 gift cards upon completion. So as I mentioned, we looked at demographics. In order to look at dietary behaviors, we used the block fruit vegetable fiber screener. We specifically looked at fruit and vegetable intake for our study. We know when people are not consuming enough fruit and vegetables, they're at higher risk for hypertension, diabetes, obesity, and heart disease. So this is a really important measure of health. Then we used the food security 6-item short form to look at food security status. As I've already mentioned, higher rates of food insecurity are associated with both poor mental and physical health outcomes. So both of these are really important measures of health to understand, especially if they're negatively changing. And both of these screeners were developed as rapid and valid ways to analyze these 2 measures. So here are our demographic breakdowns. We had a pretty even split by race ethnicity. Our other category includes Hispanic, Black, and mixed participants. Because of sample size for those categories, we ended up combining them. We have social class, BMI classification. We calculated participants' BMI using height and weight and then classified them using CDC categorizations. We looked at living status in fall 2020. Not only was this when our study was administered, but it was also a particularly precarious time for students as some began returning to campus, others remained off campus with a parent or guardian, and others moved off campus, whereas they would have been on campus previously because of COVID protocols. The majority of our participants were female. We had about 30% male, and we had one participant who was gender nonconforming, although when we analyzed gender specifically, unfortunately, we had to leave that participant out simply because of sample size. All right, so to get into our actual results, 85.5% of our participants indicated having high food security status, and 14.5% indicated having low or very low food security status. We saw no significant differences in food security status by living status, BMI classification, or gender. That being said, we did observe a significant relationship by food security status and race and ethnicity. So our white and Asian participants demonstrated higher food security status than our other category. We also observed a significant relationship between food security status and social class. So our middle class and affluent participants demonstrated higher food security status than our working class participants. So to get into dietary changes, 63.4% of our participants indicated changing their diets, and 36.6% said they did not change their diets. If participants did not change their diets, we did not ask them to fill out the block screener, which means that our sample for this variable is smaller than it was for food security status. That being said, we did observe a significant decrease in fruit and vegetable intake before and during the pandemic. However, we observed no significant differences in fruit and vegetable intake by any of the demographic factors we analyzed, including living status, gender, race, ethnicity, social class, or BMI classification. So to conclude, our study adds to previous research about how the pandemic has impacted college students' nutrition. It had already been established that students were at increased risk for food insecurity during the pandemic, and that race and ethnicity was a predictor of this. Our study demonstrated the significant relationship between race, ethnicity, and food security status, and we also observed a significant relationship between social class and food security status. That being said, there were mixed results based on obesity, gender, and living status, and our study observed no significant differences among those three demographic predictors. Additionally, there's no previous research that's been done in terms of the pandemic on students' dietary behaviors. Our study suggests that the COVID-19 pandemic has in fact worsened students' fruit and vegetable intake, although we saw no significant demographic predictors of dietary behaviors. There are some limitations of our study. The majority of our participants were from a private four-year university, which means that our results are a little less generalizable than we would have hoped for. Additionally, this is self-reported data, which brings up the question of bias, since participants were asked to reflect on their own nutritional intakes as well as their demographic identifiers. And finally, this is a cross-sectional survey, which means that we were not able to necessarily establish causality since it was not longitudinal and we did not follow participants over time. We do believe the study has implications for university administration and for policymakers. It is quite difficult for students to obtain resources if they're dealing with increased food insecurity. There are lots of loopholes that make this really challenging, including students often being claimed as dependents, them being younger, the eligibility restrictions being quite difficult to meet. However, in light of the pandemic, we believe it's necessary that policymakers create targeted policy that address the food security needs of college students. Additionally, university administration often works more intimately with students, and we believe it's necessary that they allocate further resources to improving food security status on campus, as well as to helping students make better nutritional decisions. In the future, we hope to expand our sample size and repeat the survey. It's about 1.5 years since the pandemic began, and a little under a year since we last conducted the survey. So it'd be interesting to see the state of college students' nutrition today, especially as we begin to return to some semblance of normalcy, but we're obviously still dealing with some of the protocols and restrictions that COVID has brought along. So here are our references. I'd like to acknowledge the Rice University Kinesiology Department and my co-authors for their ongoing support and for presenting me with so many opportunities to really get hands-on experience with this research. And then we'd also like to thank the Houston area colleges and universities who participated, all the staff and faculty who distributed our survey, and to all the students who participated. So yeah, that is our presentation. Thank you so much for listening. And of course, we'd be open to any questions that come up at the end of the panel.
Thank you, Kathleen, for this super interesting presentation. I would like to know how that survey would look like today if you were to repeat it again. Thank you so much. And if you have any questions at the end of the presentation, of all the presentations, we'd be happy to look back. All right, well, please welcome our third presenters for the session, Taylor Levi and Dr. Mary Autumn.
Hi, thank you. Can you hear me?
Yes, yes.
All right, thank you. Well, Taylor and I are excited to be here today to present to you guys a presentation on an Eta Sigma Gamma student-led project. So the authors are listed here on our screen. So just really quickly, I'll let Taylor introduce herself in a second, but Taylor and Hayden and Lulu and Amber, these are co-authors that are students who are part of the Delta Chi chapter of Eta Sigma Gamma here at Texas State University. I'm Mary Odom, and along with Megan and Lindsay, we are three of the faculty who work with students through Eta Sigma Gamma. So we're excited to be here and present to you. So I will turn things over to Taylor.
Hi, everyone. My name is Taylor Levy. Can you guys hear me okay?
Yes.
Great. My name is Taylor Levy. I just graduated from the master's program at Texas State in Public Health Education and Promotion, and just really excited about this program, to be involved in it and kind of spearhead it and be involved with the students that we were educating on nutrition and dietary behaviors. So just an exciting program to be a part of. Next slide. So our overall objective of this presentation is we just want to identify challenges and solutions for transitioning our service learning community-based program from synchronous to asynchronous delivery. Now we're going to discuss the history and the background of the nutrition education program. The program that we developed the name, it's called the Food and Recipes for Evaluating San Marcos Health, which is the fresh nutrition program. And we delivered this program bi-weekly. They were nutrition education classes. We delivered them to children and adolescents as part of an after-school program at a local housing authority.
Yeah, so as Taylor mentioned, the program, the students had a couple of great brainstorming sessions and came up with the name Fresh. It was as a faculty advisor, one of my favorite sessions to see their creativity in developing the name of their program. And they settled on, focusing on not only nutrition, but elevating health, which I thought was a really nice touch for Fresh. But a little bit about the background. We're using food and fun after school as a foundation for the program. So this is a curriculum that is publicly available through the Harvard School of Public Health. And it's a program intended specifically for after-school programs, so a little less formal than some school-based programs might be. And we've included the web link here for anyone who's interested in going and checking out the programs that are available. And this program specifically modeled after food and fun, it really emphasizes having fun with the students. So in the after school program, we're often arriving at the community center and are literally watching the students get off the school bus and come in the building. And so there's lots of pent up energy. And the last thing we want is for the students to feel like they're still in school. So we really focus on making it active and incorporating a lot of physical activity where the students are up and moving and trying to engage them physically as well as intellectually. So we're focusing on teaching children about nutrition, encouraging them to try fresh fruits and vegetables. We'll talk a little bit more about providing those during the program. And then also having students directly involved in the preparation of the snacks. So bringing ingredients and allowing the students to help put together the snack that they will be eating that day, the snack that will be the focus of the nutrition content. So a little bit about the program timeline. So back in spring 2017 in January, the program was initiated. I was contacted by the community partner. They needed nutrition programming, and I was fairly new in the assistant professor line, and other faculty in our department work with this after school program, providing other things like exercise programs. And so I was approached and asked if we could deliver a nutrition program. So we said, sure, happy to get involved. And so we started with bi-monthly, so twice a month sessions, and delivered those in the spring and the summer. And then in the fall of 18 was when the partnership with the Delta Chi chapter began. And so I think most people here probably have heard of Eta Sigma Gamma, but just in case, it's the National Health Education Honorary that focuses on providing health education specialists the opportunity to network with each other, to practice engaging in the various activities of health education. So teaching, research, service, and advocacy. And Eta Sigma Gamma has local university sponsored chapters. And so the Texas state chapter is called Delta Chi. So Delta Chi really became involved with the program in fall of 2018 and has been actively involved since. And then Taylor, with her nutrition background and her connections, she partnered with the food bank, and one of the other co-authors, who I think is in attendance but isn't presenting with us, Amber, she has now taken over that partnership where they work with the food bank to identify what are some healthy fruits and vegetables that the food bank has on hand, and then they customize the nutrition lesson around the fresh fruits and vegetables the food bank donates to the program, so that we can have lots of foods for the children to try and to learn about. And then the crux of this presentation, we're going to focus on when we went virtual in March of 2020 due to COVID, in case anyone's wondering, and then also resuming back to in-person delivery, which everyone was thrilled about this semester. So we're going to focus specifically on when the program went virtual.
Sorry, I was on mute. So we had numerous partnerships in order to deliver and maintain our program activities. First, as Dr. Owen was talking about, we had the Delta Chi chapter, and that consisted of public health students who prepared, delivered, and evaluated public health programming. Second, we had our university faculty at Texas State that was able to maintain partnerships and oversee ESG student activities and projects. Then we next had our local food bank, which at the time I was working at, so I thought developing that partnership was really going to be great. And they, like Dr. Owen was saying, provide fresh and nutritious foods for the after school program. And we tailored our program around those food items that we received. And then lastly, we had our local housing authority partner, and they partnered with the Fresh program as part of their after school program. So the pandemic definitely impacted many of us, including our program. So we shifted, we had to, the university halted in-person activities in March 2020, and to meet our social distancing guidelines, the program shifted to synchronous virtual sessions, which presented some challenges. We had our program members utilize video conferencing software to deliver the nutrition education sessions live. When the community partner experienced internet issues interfering with synchronous delivery, we had to move our classes to asynchronous delivery. Asynchronous delivery methods included the creation of multiple bite-sized nutrition education videos. So we were just using Zoom as our platform, and we would have ESG students log on, and we would create our videos and then record them and then send them over to the housing authority. We also created quiz videos to emphasize key information, and that was played after the lesson, and the students can engage while they're in that setting. And then we also continued our parent handouts, which were sent home after the program. Next slide.
Yeah, and as Taylor was mentioning some of those challenges, I want to build on that idea. So I think most of us now, we understand synchronous versus asynchronous after moving to a virtual platform and a lot that we've done. But the synchronous delivery, we tried to zoom in and so have a live session with the participants and with the after school program. But a key challenge in that attempt to do a synchronous delivery was an increased burden on the community partner. So we found that, you know, she's in her 80s and was not as familiar with technology as maybe we were. And so we switched to this asynchronous delivery. We were trying to minimize some of that burden on our community partner to try to, you know, log into Zoom and make sure the technology worked and the sound worked. The location that the after school program had some internet issues as well. And then later they actually had flooding. And so the building was shut down for a while for repairs. And so there were a lot of different challenges that came up. And so Taylor led the students. She was the president of Delta Chi at that time. And she led the students through brainstorming, how can we make this better? And so the students went to their program evaluation, looked at the goals and objectives that they had built and designed the program on, specifically focusing on process and impact evaluation, and said, okay, how can we still provide these the important nutrition information and lessons to the students without having to be live. And so that's really where they came up with some pre-recorded lessons, and they really did a great job trying to keep lessons to, you know, videos 5 to 10 minutes where they would record in Zoom. And so this is an example of a hydration lesson, and you can see 2 of our students in the videos there. They also put together quizzes where they would ask questions and then pause for a minute so the students could verbally yell their answers, even though we weren't there with them to hear it, but they would pause and then they'd give the answer and talk about it as well, trying to build in some interaction with students. And also parent handouts would go home. This is an example from a different lesson, a fruits and vegetable lesson, where they would send home information that hopefully the parents would be engaged and perhaps watch some of the videos, take the quizzes with their children. And I'll turn it back over to Taylor.
Thank you. I always have to click the unmute thing. So we need solutions to these issues. So one of our solutions for the technology, the online delivery of the program was very beneficial. And as Dr. Rowan was saying, the on-site location where we delivered the classes was limited in technology, and overall education on technology. The people who were running the program, as she was saying, the director there was 80, so she wasn't too well aware of the technology. And when we moved to virtual, that didn't allow us to have communication, and because we were normally going and sitting down with her and discussing it. So technology such as PowerPoints and videos and virtual visual quizzes are necessary for the program. In the upcoming years, we want to incorporate more technology that is appropriate and feasible, along with having continued buy-in and participation from our ESG members in order to improve technological input. Next slide. And the solution for the increased burden on community partners, we can develop partnerships with community volunteers who are in person to help guide their in-person delivery of asynchronous lessons, along with providing a technology guide for on-site staff members who are delivering the lessons. Additionally, creating YouTube videos that can be played anywhere and anytime, creating smaller bite-sized videos for the students, and incorporating interactive elements to engage participation are some additional solutions as well.
Yeah, and I think I got ahead of myself a little while ago, but these were the 4 standards. These are standards from Eta Sigma Gamma for the university chapters. So part of the solution, students reworked the program goals and objectives to meet these standards. So they made sure that the changes they made still used basic theory and still used evidence-based principles when it comes to health education programming and planning. They reworked their goals and objectives, but kept them measurable. That was standards 1 and 2. And then with standards 3 and 4, they had to rework some of the materials and methods that they had originally created to fit the new revised goals and objectives. And then when it came to standard 4, we actually, for the first time, we weren't able to really measure impact perspective. We tried, it didn't work very well. So we were able to measure process when it comes to standard 4. And that was well done. And then Taylor mentioned this briefly. We did see some advantages to the asynchronous programming. We saw that there was an increase of ESG students who were able to participate. So our students at Texas State University, they tend to have jobs and families and lots going on. So it can be difficult for them to make it to campus. And a lot of our students drive in from far distances to attend classes. So it can be difficult to attend in person. So when we went asynchronous, we saw an increase in the number of students who were able to help. And that's actually something we've carried over to this year. We have a Zoom component to all of our in-person meetings.
Another advantage to the asynchronous programming, we were able to restructure our lessons. And by creating short videos, we were able to easily divide up the videos among our group members. And we were able to improve community partner accessibility as well. Since the on-site location had limited technology, our plan for the future is to incorporate more technology that is feasible for our partner and to have continued buy-in and participation from our ESG members. And thank you guys for watching. This is the end of the session. So if you, of course, have any questions, we are more than happy to answer.
Thank you, Taylor and Mary, for this great presentation. And now we're gonna open it up to questions. If anybody has any questions regarding any of the presentations in session 4, this is the time. We have one question for Dr. Odom. What were the safety measures in place to deal with any food allergy reactions, if any?
Yeah, so we actually asked the community partner, and the students who were attending the after school session, they were attending as part of a broader after school program, and they had lots of food provided by various food banks. I think there's 2 or 3 food banks providing snacks and dinners. So we asked if there were any food allergies, and we were told there were none. So that's something that each year we just continually check and ask. And then we really relied on Taylor with her registered dietitian background, that if we had something like peanuts that may be a common allergen, we would run the ingredients by the director and she would let us know. But we, in 5 years in the program, and we've never once had anyone say, yes, there's a food allergy, which I think is quite remarkable.
Thank you for answering that question. Megan asks, what length for the videos do you find optimal for the online program?
Dr. M, do you want to take that one away? Because when I was in the program, we were doing the virtual, and then I don't think there was the evaluation of if they enjoyed like the 5 to 10 minute videos. So I think Dr. Odom might have a little bit more insight on that.
Yeah, so we chatted with the director, and we also pulled from practices that we use for creating videos for our students in our university classes as well. And so we would try to keep the videos to about 5 to maybe 10 minutes, but I think most of us, we really struggled to keep them under 10 minutes. So we tried to chunk and have several shorter videos, and I think that worked. But like Taylor mentioned, we tried to do some feedback from the community, but didn't really get any responses in online surveys. We weren't there in person, so it was a little harder for us to measure that. But in informally speaking with the director, she said the shorter the better. And I know that's a very vague answer.
I would say, just piggybacking off of that, when we would do the in-person classes, we did keep our lessons very short, 5 to 10 minutes, and they were able to kind of maintain attention in that sense. And so if you can translate in person to virtual, yeah, the shorter the better, especially with children.
Thank you. Are there any other questions? Oh, we have another question. Has your program connected with foster homes?
I would say not, definitely not yet. That would be a really great venture to start that, though I'm not really sure of the area that within where we were doing the program. I'm sure there are foster homes there, but expanding the program would definitely be very important. I was working at a food bank at the time, so we were able to reach those. So just continued partnership development is going to be really interesting as the program progresses throughout the years, but that's definitely a good avenue to start expanding the program.
Thank you.
I also
Are there any? Oh, sorry, go ahead.
Yeah, I'm just thinking, piggybacking off of that. So when I was doing classes at the food bank, I was working at a youth respite center. And so I was not able to perform virtual lessons with them due to privacy and confidentiality with those students. So I wonder if that would roll over into the foster care setting as well, keeping their identities just confidential. So foster home might not even be an option, but like I said, you can always broach it and see if that's an avenue to go down.
Thank you. Any other questions? Last call. Well, thank you to all of our presenters for these excellent presentations. We're very happy that you could join us for this conference. I'm sure all of our audience loved hearing about your very relevant projects and insights. And now for the next session, we have a networking lunch where we're going to talk about advocacy. We'd be happy if everybody could join us for that. And I'll hand it over to Haley.
Thank you, Eva. So we're going to go ahead and we do have a break period in between this session and our working lunch. So if you want to grab a snack or grab your lunch and then just come back in about 5 minutes, we will go ahead and introduce our speaker for our advocacy session, who is part of the National TSOPHE Advocacy Committee. So we will go ahead and see you all back in about 5 minutes.
All right, welcome back, everybody. Good afternoon. My name is Allison Shea, and I'm part of the TSOPHE board. Today, I'll be moderating your working lunch session with a focus on advocacy. And we have our presenter for this session, Dr. Megan L. Smith. She is an associate professor in the Department of Public Health and Population Science at Boise State University. And Dr. Smith received her PhD in Human Development and Family Studies from West Virginia University in 2015. She has a teaching degree from California State University, Chico 2008, and a BA in psychology with an emphasis on diverse populations and education from the University of California, Santa Cruz, 2006. Dr. Smith builds on education, human development, and public health science to study the contextual factors that promote or thwart health outcomes, particularly substance abuse, mental health, and sexual risk behavior for young people. She previously worked as a K-12 teacher and focuses on the school environment. While working for the WVU School of Public Health, she served as Director of Child and Adolescent Health Initiatives for the Prevention Research Center. She is proud to be a member of the International Planet Youth Team to promote the notion that the true prevention is possible if you start at the community level and change the culture of health. She is committed to public health advocacy and deeply believes it is the mission of the public health professionals to continue to advocate for and champion equity and health for all. So we ask that you hold all questions until the end of the session for our presenters, and let us welcome Dr. Smith.
All right. Hi, good morning, everyone, or I guess it's afternoon where you are. I appreciate being here, and I really appreciate the interest in advocacy, and hope I can share some information that's helpful or inspiring, or just inspire some questions for you. And I will make sure that's the case. So I'm going to share my screen if I'm allowed to, and I apologize, my computer is moving at a really slow, weird pace right now. All right, so you should see the first slide. If someone just wants to give me a verbal yes, it's hard to see y'all when I'm sharing.
We can see it.
Okay, excellent. Thank you so much. I guess this lunch talk is about state level advocacy and understanding how that advocacy can empower our communities. So I'll start sort of broadly. I'm imagining that this audience has a spectrum of either full-blown advocates or just interested advocates. And I hope that parts of this presentation touch and inform all those levels. I will say that I am currently the co-chair of the SOPHE National Advocacy Committee, and that if any of you are interested in advocacy, we would love to have you at those meetings. We meet monthly, and it would be, and we change, when our meeting schedule is based on participation. So if you're interested in that, my email address is at the end of this slideshow, and you can go ahead and contact me there. Okay, so first, just starting, so we have a common understanding of advocacy. I know that in my experience, there are many folks who think of advocacy and only think of lobbying. So only think about talking to and trying to convince policymakers of things. And advocacy is a lot of different parts to it. And so I just always like to start with the basics. Advocacy is about organizing or mobilizing the base. It can also, and that means like whoever might be interested or affected by your particular issue. And then it's also about educating legislators or the public, and that can be a lot of different ways. So we use letters to the editor, which sometimes seems silly to people because they're like, who reads the newspaper anymore? But early on, we realized that both state and federal level legislators, sometimes because they're so busy, that's one way to get a snapshot of what's going on in their constituencies. And so letters to the editors, they actually, as a practice, they have a staffer collect all the letters to the editors and they look at them each day. So those are actually a kind of a great direct communication route. One pagers, which are what I'm sure you've seen, like a white paper about a particular policy or issue. It can look like news generating activities. So how do you get the media to look at you? And we'll talk about that a little bit later. Advocacy is research. So if we can create and generate research that supports a particular initiative, then we are doing advocacy work. Training future advocates, which I'm sure some of you do, and then also lobbying, right? Which is that direct contact. There's also some more examples of advocacy. So identifying issues, research and analysis, educating the public, lobbying for or against particular legislation. Voter registration drives is advocacy, particularly in disenfranchised or disempowered communities. Voter registration can be a beautiful way to get people re-energized about particular things. Down at the bottom is testifying. So all of us are specialists in certain areas, and if we testify or participate in hearings with government bodies, that's part of advocacy work. So some examples of this in action is at the local level, at city councils, say, we can make some health changes or policy work, either by, on the left, you see testifying in front of a government body, and then on the right, organizing, educating the public. So these are actually pictures from West Virginia, and we were working on a non-discrimination ordinance. So in the state of West Virginia, at the state level, it's still legal to discriminate against people in the workplace for sexual or gender identity. And so we had been working at the state level a lot, and that's why I think this is a great example for this crew. We had been working at the state level a lot and not making much progress. As I imagine some of you face issues when you're at your Texas state policymakers, that it's hard to make big change, particularly right now in our political context. So what we decided to do instead is to put pressure on them by going city by city and getting non-discrimination ordinance passed. So at this point, even in West Virginia, where you might think it's a similar kind of challenging battle to get non-discrimination ordinance passed, we now have 15 cities with these non-discrimination ordinance passed, which is great in two ways. One, the more cities that sort of put their stamp on this, the better off we are to get state support. And we also are making real current change in people's lives who live in these cities, right? So instead of making them wait the years it would take to get it turned in the state, we're going city by city and changing lives right there on the ground. At the state level, advocacy can look at like building relationships with legislators. So on the left-hand side is the wonderful Danielle Walker, who is a state legislator. And we like to meet up with her and talk to her and make sure that she knows she has our support and what we're kind of interested and curious about. And then we also went and met with the federal level senator. This particular senator has been in office for a very long time. And so this was an approach to ask him to use his power and influence to influence our state legislators' decision-making. And then again, some examples at the federal level of advocacy. So meeting with experts and constituents. So this was particularly in West Virginia. As you probably know, we have, we're kind of the epicenter of the opioid epidemic. And Medicaid would only pay for 16 beds at a time in one facility, which was problematic in West Virginia, where we have more need than 16 beds. And so we met with Senator Capito to have her expand that, and she was actually able to do it. So that was pretty cool. And then this was about, this was a campaign we did to put pressure on Senator Capito to extend ACA. I don't know if you recall, but back in 2017, there was a lot of fight over whether ACA would survive or not. Unfortunately, even though we did this campaign, Senator Capito did not vote with us on this one. So the next thing I want to talk about is just the advocacy checklist. And I think this is really helpful for beginning ally advocates to think through the key steps in any sort of advocacy campaign. One is you really want to identify your issue and what the real problem is. You know, as you gain excitement around a particular issue, you may get lots of diverse folks at the table. And it's really important upfront to clarify what actually you're going to work on. And that leads into step 2, which is defining and clarifying your goal. So what do you want the policymaker to actually do to solve the problem? So many of us are like, oh, we're mad about this and we want to yell. And we forget to sort of define and clarify our goal. And what happens is twofold. One is we're not able to ask for concrete things from folks like policymakers. And also we might create some tension or some conflict within our coalition or group of folks working together if we're not really clear on what we're working for or toward. You want to know your audience. So you want to think about who actually has the authority to accomplish your goal. You don't want to go and set up a meeting, for instance, with a state level policymaker for a more city, county, or federal level problem, right? So you want to be thinking about who are the people that actually have the power of the lever, and those are the people we want to communicate to. You also want to know them really deeply. I always say do your homework on your policymaker. So you want to know anything about them that you might be able to utilize to build a connection or a relationship with them. For instance, in the example I gave with Senator Capito, she has several granddaughters and likes to do a lot of work with them. And so we made sure to always try to tie back to sort of young girls' work, like how could this benefit young girls? And that gave us 2 things. It gave us a way to connect to her, and it also gave us a way to sort of tie our goals to her goals. And then you want to learn the process. So what are the opportunities to accomplish your goal, right? So what are the policy windows, or sometimes we have this moment where society is really interested in something. I would say right now, I imagine most of you are public health professionals. And right now we have this opening where people are really looking at how schools support. I think a lot of people, particularly in this nation, just saw schools as sort of academic places. And of course, as public health professionals, we see them as more than that. But now society at large in the nation is looking at schools as so important, right? We can see that they provided social support, food support, family support during the pandemic. And so there's a moment here where we could really leverage this experience and this new sort of wide open eyes on how important schools are for our young people and for our communities and for our families. And this is that opportunity. So we should be using it. So if you're in school health or you're excited about that, let me know. Step 5, finding your allies. So again, who else shares your goals, and thinking really deeply about who this might be. So if you think back to the example I gave at the beginning of the non-discrimination ordinance, we knew that some of our opposition would identify as faith leaders, and we knew that some of our opposition would identify as business leaders. And yet we know both of those groups of humans are very effective in swaying public opinion and also in swaying legislator opinion. And so what we did is we went out and sought business owners who would support a non-discrimination ordinance, and both had them sign on and be official champions for our issue. But we also gave them public recognition in their window so that people would know. So they got sort of something good for them, something good for us. And so that's a way to really think about who are our allies. We also reached out to faith leaders who we know would support a non-discrimination ordinance, and we had them on the front lines as our communicators so that we wouldn't have the false notion that faith leaders are one way or the other on this. We wanted to really open it up and make it clear that faith leaders do support non-discrimination ordinances. And so that's what I mean, not just find your allies, but find like the really key allies in your campaign. And then it says develop your message, and we'll talk about this more specifically in later. Sorry, I'm just the chat's happening. I'm just checking the chat. Sorry, I got distracted. I want to make sure no one had like a burning question right now. So in developing your message, like I said, we'll talk about that a little bit later. We'll actually have a moment where we can maybe practice and play with some messaging ideas. But it's really important to have a key message. And again, it's not just about having that message. It's about being able to say it over and over and over and over again, and being able to communicate it so clearly that anybody in your coalition can also state that same message. And that becomes really important, particularly as your campaign comes from behind the scenes out into the public or the media, because media, depending on their particular ideas about your advocacy campaign mission, may present kind of interesting sound bites. And so if you just in your interview repeat your same key message over and over again as many times as you can, then media only has the option to play that in their news clip. And I learned that the hard way early on. And so I always encourage people, know your message, have everybody in your group be able to say your message. And that helps make it really clear, right? And it makes your message so that anybody in the public understands what your advocacy is about. What happens so often I see with messaging is that we don't really put tons of energy and effort on it group wide. We may have a great message, we may be able to use it on social media, but in our coalition, our advocacy team, our community group, they may not have that message. We may not have practiced it with them. And so when they go out and talk about what our advocacy campaign is about, sometimes they miss it or they sort of misrepresent it. And then that can go pretty poorly if people are like, well, what is this about, right? I think, yeah. And then you want to prepare any written materials, right? So you may have 20 minutes with a policymaker at the state level, and you're obviously not going to be able to explain all the intricacies of the topic that you're talking with them about. So you want to make sure this is that one pager, just a one-page information sheet about what you want them to do or the information about the particular issue. And then you want to really think deeply in step 9 about your strategy. So often people jump to the idea of what it looks like on the outside, right? So they jump to the idea of let's have a protest without thinking first about what is the strategy behind that and how does that link to the goals? And we'll unpack that a little bit more later on too. And then finally, step 10 is following up and building a relationship. So if you have a policymaker at the state level, it is really important early on to think about what type of long-term relationship you want with this policymaker. So often people come into advocacy again with an idea of what it is, and they think about that, you know, like burning the Capitol down, right? They're so mad and they're revved up, which is great. That energy is awesome. But you want to think, is that the type of long-term relationship that's useful to your goal? Now, sometimes it is. We know that some state legislators are absolutely in opposition, and the only way to sort of push on them is by that mentality. But you really have to analyze who that policymaker is, how long you think they're going to be in office looking at your issue, and whether or not it's important to have a more positive relationship build. And then you want to maintain contact with that person. So many of newer advocates, we have that first meeting with our policymaker, we're really excited we did it, and then we don't follow up. And what happens then is the office can then ignore you as an advocate because you are not annoying. You are not in their email box. You are not talking to them frequently. So the best thing to do when we get that policy meeting is actually the follow-up. So 2 weeks later saying things like, hey, remember when we met? I just saw this news article about X issue that we were talking about, and I wondered how you felt about this. You basically want to be sort of the phrase bee in their bonnet. So you want to make sure they know that you're present, that you're paying attention to them, and that, you know, depending on how you want to categorize that relationship, that you're a positive source of knowledge. A lot of us working with SOPHE are health educators. So that means we really want them to turn to us for health topics, right? So thinking about how you can set up and maintain that relationship. I'll pause here for a second if there are any sort of burning questions at this moment, and then we'll work on some practical skills. Okay. right, so there are some practical advocacy skills that I like to highlight for promoting health. And I know y'all are focused on the state level, and these are really practical advocacy skills for any level. But these are the 3 things that if you are brand new to advocacy, these are the things I would say you want to really work on. Analyzing key stakeholders in an advocacy campaign, right? So going back to that idea about who do we actually need at the table to be champions for this, who are maybe unthought about advocates about this. Again, thinking of the example with the non-discrimination ordinance, who are the faith leaders who would support us so that we make sure that it doesn't get turned into a faith argument, right? So that we know that that is a key stakeholder we need to have at the table. The second practical advocacy skill I would say is creating an effective message. So again, we talked a little bit about the importance of messaging, and we'll go into some detail later on in this presentation. And then finally, identifying the key best practices of effective organizing. So what works for advocacy campaigns when we look at the research and successful campaigns? So you, I don't know why those are question marks. So in analyzing key stakeholders, you want to think about what are the foundational pillars for success. So in this case, for the non-discrimination ordinance, it was at the city level. And we knew some stuff about what was going on at the city council level. We knew that very few people voted in city council elections. So what we did is we recruited 7 brand new candidates for city council. And then we recruited tons and tons of new voters for city council. And that really helped us build a foundation for success, right? At the state level, you can really do similar things where you are looking for particular state legislators who would be new for running for office, who would be favorable to the issue that you're advocating for, right? And then you work hard to get that person elected, and then you work hard to maintain a relationship with that person and give that person support. You also want to think about harnessing multiple forces through ad hoc leadership. So often when we think of advocacy, we think of like one leader or a hierarchical leadership model, but that actually discourages some groups to work together in coalition because they're like, whoa, we're in charge of human rights and that's our thing. Why would we work with you, right? If you're going to try to lead us in this. So instead, it's better to bring sort of the leadership from all or any associated groups together and to work it out as a team together. How will we share this leadership, right? So that no one group feels like they have to give up their processes to one other group who happens to be the lead advocacy or the lead advocate. So this looks like having communications about the communication chain. Who's going to be communicating with the legislator about what, who wants to be involved in that part of it, who's going to be educating the public about it, who wants to be involved in that part of it, who's going to take that lead, and really working hard on creating shared leadership. I have seen beautiful coalition work, and I have seen coalition work where people come together and it becomes sort of a power dynamic struggle for who's going to be really in charge on this or who owns human rights, for instance, which is really odd when you think about advocacy, but it's also human nature when you bring lots of diverse folks together. So I always advocate for having sort of an ad hoc leadership structure and a more sort of shared leadership rather than putting one group in charge. And this works pretty well if you get all those people together and really hammer out the details, right? We made sure that all people in our coalition, their branding was on every message that got sent out. So no one felt like they were left out or being excluded from the work. And then finally, cultivating key champions, right? So is there a huge donor in your community? Is there just a leader in your state that people turn to that you wouldn't necessarily think about around your advocacy issue, but could they come to your team, so to speak, and be a leader on that, right? So thinking about who are the people that at the state level who people in the state listen to and talk to, and let's go set up a meeting with them and say, hey, will you champion this issue with us? And so really cultivating those key people who will be important. like I said, the faith leaders and business leaders were really our key champions in the non-discrimination ordinance, because we knew there would be the appearance that those folks were not on our team. So we wanted to make sure that that was really obvious. The next skill that we're going to talk about is creating an effective message for your advocacy campaign. So there are a few things about messaging, and I think these are the three things, again, if you're a beginning advocate, or even if you have lots of experience, that sometimes get lost in our messaging. One is we want to offer the positive transformational story. The second is that framing is really important, and I'm going to unpack all these in a second for you. And then finally, packaging your message for sharing, right? So offering the positive transformational story, what do I mean by that? I mean that so often when we're advocating for issues, we're unfortunately advocating because something is a real problem, right? It's, you know, I do a lot of children's health advocacy, and it's really hard to talk to people about child abuse or child hunger, right? And what happens is a natural human thing, which is called compassion fatigue, right? Oh, it's so bad, it's so negative, I can't handle it, so I'm going to basically tune it out. And I know all of us in this room probably have an issue that we have compassion fatigue for, right? So often I get just bombarded with so much stuff, and I'm just like, oh, I gotta just step out for a second. And so one of the effective ways to message about a problem or an issue is telling the positive transformational story. So in this case, I have a picture of a caterpillar. We need to tell the caterpillar that if you do all your work, you turn into a beautiful butterfly. And let's talk about what that looks like. That looks like you can fly. That looks like you have all these bright colors, right? Whatever it is. And so for our messaging, we need to think about, what does it look like if we get everything right in this advocacy campaign? Like if you, policymaker at the state level, if you can do what we say, what does it look like when it's beautiful? And so I always say, make sure that's part of your story. If we just tell what's wrong, then we're actually just like messing with human psychology and having them turn us off. So we need to add that piece about what does it look like transformationally. The other thing that's really important is framing. And so I'm not sure where we all are on framing. There's lots of resources on framing and the science of framing. The one thing I'll say here is that when I share this part of it with my students, they will say, well, you know, some things just aren't framed, or I'm not framing this, right? And that's actually not the case. Everything is framed. And basically a frame is something that lights up particular values in everybody's brain when they hear your message. And so we sometimes don't think about framing, and we use the opposition's words, and then we light up those parts of the brain when we're trying to communicate with someone. So you want to think about, one, how can you frame what you're saying so that it highlights the overarching and shared value or goal with whoever you're communicating to, right? And so that can be pretty easy if you're talking to someone who's mostly kind of agreeing with your issue. And it can be pretty hard, and you might have to come up pretty high to think about what are the shared goals, right? So thinking about what you emphasize when you're talking to that particular audience, and how and what you explain and what you leave unsaid, right? There are certain things that if you say this one word, for instance, right now, it seems like when we use the word social, it triggers socialism for lots of folks. And so thinking about not using that word, but being able to communicate the same context. And finally, this is what I was talking about earlier in the presentation about really making sure your message is easy to share, making sure your message is tight. Here is one formula for making a really great tight message. And this is that it's called the 2793 rule. And you should generally have a message that's around 27 words, that's about 9 seconds long, and that has about 3 points to it. There is a mediocre example in light blue at the bottom of your screen, but this will really show you some of the ways that you can effectively message. Now, what I would say is once you create this message, you want to share it as widely as possible. What's great about it is once you have it, you can put it out on PSAs on public radio and TV. You can write it in letters to the editor. You can put it in social media posts. You can have everybody in your coalition train on this message and know this message, so that no matter who they interview at a particular gathering or media event, this message gets out into the public. All right, and then finally, let's talk about the last skill, which is identifying key best practices in effective organizing for advocacy. So there are 3 parts of this one for me. One is being strategic about your approach. Remember the long game. So we know that so much of our work is a slog, right? It's not like we just go in, we ask for it, and boom, we get exactly what we want. Right? And so we need to think about what is the strategic approach for the long game? If I want this to be an ultimately positive relationship with this person, what do I do and what do I not do in order to get towards my goal? We can't think about just right now, like, well, we're mad, right? We have to think about the long game. The second one is efficient energy use for maximum change. I will talk about the spectrum of allies, which is one of my favorite aha moments of being an advocate. And then finally, recognizing the effort and importance of your community. And this last one is truly important as you build coalition. And remember, you want to play the long game, not only with the policymaker, but also with the folks you bring together in community engagement or in your advocacy campaign, right? You want the coalition members to feel important, like they matter, that they are recognized, that they have good relationships with each other. And so a lot of the work within a coalition is super important for that long game, right? And we'll talk about that too. So the first thing is thinking about goals, strategy, and tactic, right? When we think about the long game, so often what folks do is go right to the tactic, okay? They think, okay, we're gonna have a protest or we're gonna have a letter writing campaign because they know that or they've seen that. And instead, what you wanna do is think first about what is your long-term goal and think about sort of the measurable outcomes that build you to that goal, right? And then you think about your strategy. So this might be embarrassing our legislator, or it might be educating our community, or it might be getting some key champions. Those are strategies. And then the tactics are those activities to implement that strategy. And I have a few examples I'll share with you. These are all sorts of different tactics, right? So here is an example of a town hall where we invited our policymakers at the state level to come get them on record about their feelings about health in our state. This was earned media. So we made sure to meet outside of one of our senators' local offices every week. And so eventually the media came and took pictures of us doing that. Here is a Save the Children advocacy meeting with one of the Idaho state legislators, making sure that they knew that we were paying attention, that we wanted a relationship with them, and that we really cared about children's health and their votes on that. So we would sit in their committee hearings with our shirts on, so they knew we were there after we met them. So they kind of saw us watching them make decisions about children's health in the state of Idaho. This was an example of an advocacy campaign here. So it seems far away now, but around 2017, their ACA was on the chopping block. And one of the things that people didn't really know about it, because they were calling it Obamacare, were some of the key pieces of it, right? And so they didn't know that their pre-existing conditions became protected when ACA went into effect. And they didn't know that Medicaid was expanded. So particularly in this state, which was West Virginia, it was really challenging for people to understand why they would be pro-ACA. So we started doing an education campaign on key major public roads where we had like a table of information and where we had all these signs to get people's attention, to let them know what ACA was, why it was important to save it, and how it actually impacted them and their families' lives and health. Okay. This was what I'm talking about with my big aha moment as an advocate. So often when we think about advocacy, if we're in active support, we think that we have to change this active opposition piece over here, right? You imagine it in your head, you think about the person who's gonna literally scream into your face and throw things at you, right? And actually what we find is that that is a lot of effort, it's a lot of emotional energy, and it doesn't do as much work for our advocacy campaign. And so actually what could be really effective for advocacy, and it takes less energy, is maybe taking these neutral people and just moving them into passive support. So I love thinking about an advocacy campaign in the context of this spectrum of allies, because what it says to me is that if we just move one wedge, one to the left or one to the right, depending on how you're thinking about your issue, you can really, with less energy and more efficiency, make change on your issue. Imagine what happens when you move all these people from passive support, right? Oh yeah, I totally believe, LGBTQ folks should be able to get married, but I'm not going to do anything about it, right? If you just move those folks into active support, now you have all these other things. Whereas you could still be yelling with people who are like, absolutely never, right? And so this is something that I really find hopeful about advocacy, and I like to share it with newer advocates so they understand that you don't necessarily have to take those abusive or emotional or toxic, however you want to think about those very high conflict situations. That's not the only advocacy that's out there. And in fact, moving someone, for instance, from passive opposition to neutral is really impactful for your particular issue, right? They're no longer going to be sort of talking to their friends about how they don't really believe in it, right? They're now going to be neutral. So they just will sit out of that argument, and that is helpful. So I highly recommend looking at the spectrum of allies. I think it's a great tool, particularly for new advocates. That's a practice, but I don't think we're going to do that today. I think I'd rather just leave some time for questions and answers. So I just wanted to leave, I always like to end with this when I'm talking about advocacy, because so many people, particularly health educators, we know that the work we do is both important, it's meaningful to people's lives, and it's hard sometimes. It's hard to get people and policymakers at the state level to make those changes. I know I live in Idaho. I know our legislature is very similar to Texas at the moment. We're kind of following each other. And so I say this to people because when people get into advocacy at the beginning, they may feel very sort of dissuaded or down about the work they do. And I love this quote: "The only kind of fights worth fighting are those you're going to lose, because someone has to fight them and lose and lose and lose until someday someone who believes as you do wins." And so I always try to keep this as my mantra, right? So even if I'm losing in this moment, I'm still building political will, I'm still building knowledge, I'm still connecting more people to the issue. So we're still taking steps forward, even if we're losing, right? All right. So I love questions. Here's my email address. If you are interested in joining our SOPHE National Advocacy Committee, we would love to have you. We are actively writing resolutions. We just passed several that may be pertinent to y'all. One was on women's reproductive health. We just passed one on LGBTQ health issues and health equity. We are writing one currently about racial health equity. We just love new advocates to come to the committee to help us. And what we do is not only write those resolutions, but we push SOPHE forward on particular advocacy topics that we think are important. And I love questions about advocacy and also adolescent health, which is my specialty area. So please feel free to email me, and I hope that you feel welcome to do so. And now I will leave time for some questions and answers.
Thank you so much, Dr. Smith. That was a really great presentation. I hope everybody found it very helpful and informative. So now we will open the floor for questions. If you have any, you can either unmute yourself or put them in the chat.
Oh, thank you for the positive. Go ahead. Yes.
Oh, sorry. No, I was just checking the Q&A box. So Eva asked, do you recommend attending the advocacy summit, and what is that like?
Yes, I do, especially if you're a newer advocate or someone who just wants to brush up on your skills. So we just closed our SOPHE Advocacy Summit this year at the end of last week, and actually are doing Hill visits virtually today and yesterday. And so what that looks like, Ava, is you get 2 days of training. It's usually around a particular topic area. This year it was health equity because we really wanted to push forward on racial equity given the constraints of our current society in this nation. And so the focus was that, and there are always workshops to practice advocacy skills. For instance, some of the things I shared with you today, we actually workshopped and trained on the skills and like practiced our messaging and things like that. And then there are also content area presentations around this year, all around health equity. So how do we advance health equity in these communities who have been marginalized in our society? And then finally, you get some training for how to meet with a policymaker, and then you actually can meet on the Hill. And hopefully next year, when we're more post-pandemic, we can go back to our old model, which was we literally go as a SOPHE team. It's so beautiful to see hundreds of us go on to Capitol Hill in DC and have hundreds of meetings with our legislators. This year, we had 2 asks. One was to have our senators support the social determinants of health bill, and the other was to support the Black Moms Momnibus bill, which supports maternal and infant health initiatives for Black moms in our country. Yeah, you're welcome, Eva. Are there other questions or answers for me? I know we don't have too much longer, but. Yes, so Thomas, each year there are several scholarships for summit attendees, students. One of the routes to those scholarships is just by indicating that you're interested in your registration. And then the other route is by submitting your own student research and having that research selected. And scholarships are available. I think we did about 14 student scholarships this year. And I'll do a plug for our Masters of Public Health program at Boise State. If you're interested in coming to Idaho and learning more about public health and you're interested in advocacy, we would love to have you at Boise State Public Health. And you can, again, email me about that and join us there if you are not doing your MPH yet. I appreciate all the feedback. Thank you all. It's been a pleasure working with you today and meeting with your lunch chat.
All right. Do we have any more questions? Last call. All right. Thank you so much for this presentation, Dr. Smith. So if we don't have any other questions, we can move into a brief break and reconvene at 1 p.m. Central. All right, thank you.
Take care. Thank you.
Hello.
Hello, how is everyone?
Good. How are you?
I am good. I was having a little difficulty. My link wasn't working. And I am not Haley Delgado, so apologies, everyone. I'm not sure the disconnect, but I am your moderator for today's session, and we will start in just a moment.
If you do join through this link, you can go ahead and just rename yourself just so that it aligns with.
Got it. Done and done.
Great. Let's see. Who else should we need to add? We need Ashley. I believe y'all have been. Emily.
I think all of our speakers are here. Oh, no, we are missing Alejandra.
Okay, let's see. Are we still waiting for Alejandra? Maybe is she AA in the attendee list?
Hold on. I am following up.
Great. We have time, so we're going.
Oh, I thought we were already 5 minutes behind.
Oh, no, so we do have like our session times have buffers and transition periods built into them. But
okay,
just to give some time for people to hop on. Do you want to get started with Alejandra or?
I'm still seeking information.
Okay.
We can also switch the order of the presentation if need be. Would you like to do that?
That works for me if
Natalia and Leticia are all right with that. Yeah. All right.
I'm okay with that. Yeah.
Okay.
Leticia, I'm okay.
Great. All right, Haley, do you want me to get started?
Yes, ma'am, that works. Thank you, Jen.
All right. Good afternoon, everyone, and thank you for joining us for session 5 of the 2021 TSOPHE annual virtual conference. Today's session is entitled Digital Health, Health Communication, and Health Literacy. My name is Jennifer Hedaya, and I'm a member of the TSOPHE board as well as the planning committee, and I'll be your moderator today. The structure of the session, I'll begin by reading your authors' bios, and then your presenters will give their presentation, and we will ask that you hold questions until the end, and we will ensure that there is time to answer questions before the end of the session. So I'm going to start with, it's a slightly different order than what's on the slide. Actually, our first set of presenters is the group listed on the right-hand side, and I'll read their bios first. They are from my own organization, Legacy Community Health, so I'm very thrilled and honored to introduce them here today. I asked for this session just so that I could do that. And I'm very proud of the work that they've been able to accomplish in the presentation they'll be giving you. 3 presenters will be presenting from Legacy today. The first is Alejandra Zuniga, or this may not be the exact order of their presentation, but I'm reading their bios in this order. Alejandra Zuniga is passionate about patient education and helping individuals meet their health and wellness goals. She completed her Bachelor of Science in Human Foods and Nutrition at the University of Houston in 2014. She has 7 years of public health experience and has worked as a nutritionist, patient care coordinator, and as a health educator in the peripartum pediatric navigation program at Legacy Community Health. In her current role as a public health manager for Legacy, Alejandra provides support for effective implementation of core public health strategies and new initiatives, including health education and promotion, group and individual level behavior change interventions, and linkage to care. Her co-author is Ashley Minkyu, who is a director at Legacy Community Health's Public Health Department. She has 14 years of public health experience in the areas of volunteer management and engagement, maternal and child health, process improvement, HIV prevention, and supporting collaborative partnerships to accomplish the goals of all stakeholders. Prior to joining Legacy, Ashley served as Harris County Public Health's volunteer and internship program coordinator, where her efforts were aimed at training the future public health workforce and engaging community members interested in contributing their skills and interests to accomplishing the mission and goals of the department. Ashley completed her Bachelor of Science in Biology at Xavier University of Louisiana, her Master of Public Health at the University of North Texas Health Science Center, and her Master of Healthcare Administration at Texas Women's University. The third co-author on this presentation is Emily Rodriguez. Emily graduated from Texas A&M University with a Bachelor of Science in Health in 2017. Her first job after completing her undergraduate studies was with a nonprofit organization as a wellness program coordinator. During that time in that position, she gained experience and worked closely with the registered dietitian and diabetes educator with the chronic disease programs. She then moved on to work as a health strategy specialist at American Heart Association and the community impact team, where she gained more experience, knowledge, and skills in working with programs designed to lead and provide patient education. Emily now works with Legacy Community Health as a health educator and project coordinator, helping lead the Pharmacy and Public Health Alliance and provides patients on-site health education. Our second presentation also has 2 co-authors. I happen to serve on the abstract committee for this conference, so I am very excited to hear their presentation as well. And those 2 co-authors, again, perhaps not in order of their presentation, but in order of the bios. We first have Dr. Leticia Gonzalez Castro. Dr. Castro has dedicated her career to helping students and families with educating and advocating for their educational needs. As a professional social worker, Dr. Castro focuses on educational and mental health concerns. She has been in the educational arena for the last 20 years, working in public and charter schools. She earned her doctorate degree in leadership and management from St. Thomas University and her master in social work from the University of Houston. Natalia Williams has been a certified health education specialist with UT Physicians for 2 years, managing the wellness programming at community clinics in Houston. Her professional passions are working for the improvement of health outcomes for vulnerable populations, especially women and migrants. She graduated from the City University of New York's Graduate School of Public Health, which is where she is from. So again, we ask that you hold all questions until the end of the session for our presenters. Also, all CHES and MCHES attendees will be required to complete an evaluation for this session in order to earn your CHES and MCHES credits, and we will make that link available at the end of the session. So the order in which we'll present, we will hear first from Ashley, Alejandra, and Emily on the Public Health Pharmacy Alliance. And then we will hear from Natalia and Dr. Gonzalez Castro on a series of workshops for parents of children with ADHD. So again, welcome to session 5, Digital Health, Health Communication, and Health Literacy. I now turn the floor over to our first presenters, Ashley, Alejandra, and Emily. The floor is yours.
I think I need permission to share my screen. Or,
Oh, 1 second. I need to stop sharing.
awesome.
Sorry.
No problem.
There you go.
Thank you. All right. Alrighty. Alejandra.
And I will do the honor of starting. My name is Alejandra. This is the presentation for Legacy Community Health Pharmacy Public Health Alliance, increasing patient access to self-monitor blood pressure and glucose monitoring. And our awesome fearless leader, Jen, presented our bios. Thank you. The presenters will be myself, Alejandra, Ashley, and Emily.
Oops.
The objectives for this presentation is to identify emerging health education practices based on a cross-disciplinary public health pharmacy collaboration in FHQC system, describe challenges encountered with the cross-disciplinary collaboration between departments, and identify organization-wide solutions to enhance health education practices to address patients' needs. Last objective is to identify specific tactics participants may apply as health promotion practices in their own communities. And I'm gonna get started with some history of Legacy. So Montrose Clinic was founded in 1981 to provide STD prevention, testing, and treatment to gay men. In 1994, the Montrose Clinic consolidated its programs into one modern facility. 1996, Legacy began offering women's health services. In 1998, primary care becomes available to indigent persons living with HIV via the Ryan White Care Act funding. In 2004, the Montrose Clinic becomes a lookalike federally health center. And then in 2005, the Montrose Clinic and the Assistance Fund merged to become Legacy Community Health Services. That is the beginning of Legacy. And as you can see, we've come a long way. We have full status as an FHQC. We took over the Christus Clinic in Gulfton, creating Legacy Southwest Clinic, which is now our highest volume clinic. We partner with KIPP Academy, and we have school-based healthcare. We have expanded to Beaumont. We partner with others, community partnerships such as Houston Methodist. We've led the first ever city roadmap and the first in Texas to ending an HIV epidemic in Houston. And in 2017, we opened our own pharmacy, and we also introduced the social deterrence of health program. And in 2018, Legacy brings ground on a new state-of-the-art clinic in Southwest Houston. This is actually a picture of our LSW Legacy Southwest Clinic. And just a little fun fact, today Legacy is the largest federally qualified health center in Texas with 41 locations across Houston, Baytown, Deer Park, and Beaumont. So we have definitely expanded and we have grown immensely. This is a little bit of our Legacy pharmacy history. So in 2017, Legacy opened its own full service pharmacy at Lyons and Montrose, and the newest pharmacy, which is the Legacy Southwest Pharmacy, opened in 2020. This is a picture of the Legacy Southwest Pharmacy. Legacy by the numbers, like I showed before, we have 41 locations across Baytown, Beaumont, Deer Park, and Houston. We have 1,240 employees. We have completed 614,470 appointments. We have served more than 189,617 community members annually. 51% of our patients live at below the federal poverty level. And another fun fact, Legacy has the largest OB service line of any FQHC. And I'm going to pass it over now to my colleague, Ashley.
Good afternoon, everyone. So I'm going to talk a little bit about Legacy's chronic disease management program. So initially, well, not initially. So Legacy overall, we aim to combine self-measured glucose and blood pressure monitoring with clinical support to help patients actually meet their healthcare goals. And so a part of this work that we've been doing has been really great and transformative for our patients. And so we want to talk a little bit about how things got started. All right, so we started with two programs, the Diabetes Self-Management Program and the Hypertension Control Program. Our Diabetes Self-Management Program was focused for patients that, had a diabetes diagnosis and they can get a glucometer. However, we did have some challenges with tracking the number of glucometers that have been distributed to patients. So we made some revisions and you'll hear more about those in the later sections of the presentation. And then we also had the hypertension control program. And so with this program, we were able to provide blood pressure monitors for all of our uninsured patients that had a hypertension and diabetes dual diagnosis. So that's a big part, that the patient had to be diagnosed with both hypertension and diabetes in order to get this free blood pressure cuff. And then the devices were distributed from our public health staff, of course, in the assigned clinics via a provider referral. So if the patient was there at the clinic with us, then we could give them the device. But we did not have staff that were, for example, located at the pharmacies. Instead, the pharmacy staff could support patients as they walked in or if they had a prescription from their provider. So this is a version of our original workflows, and it really demonstrates how there was I guess, two paths, if you will, for the patient to get everything that they needed. So initially, a provider would identify that the patient had a hypertension diagnosis, and then we would check and see, of course, if that patient also had a diabetes diagnosis. And then if they did not have both, as I mentioned, they were not eligible for the free blood pressure monitor. However, if the patient did have both the diabetes and a hypertension diagnosis, then the provider could put in an order for patient education, and then our team member could work with the patient if they were uninsured or grant funded. If they were not, then they weren't eligible again for this free monitor. So the medical provider would have to write a prescription for the monitor for the pharmacy to dispense this to the patient. And then after the patient had their visit with public health, then we were able to provide the monitor and any associated documents that they needed. And then we would, of course, document completion of this order that had been submitted by the provider. And then from there, we would transition into the pharmacy workflow where the pharmacy would really work on like the medication management piece of things. So now I'm going to transition to Emily to share a little bit more about how things are currently going.
Hi, everyone. My name's Emily. So I am going to talk a little bit of how it's going and how my role actually, I was part of the pilot program. So we are going to talk about our Public Health and Pharmacy Alliance. Here at Legacy, we have a public health department that consists of patient educators that are available to provide point of care testing, individualized patient education, and of course, linkage to available legacy services. Since we have this public health department, we are now collaborating with the pharmacy department. So we have started an alliance that provides patients on site individualized health education when picking up their glucometer and or blood pressure monitor at their nearest legacy pharmacy. We have 3 legacy pharmacies at Legacy Community Health. And as Ashley previously showed, we had 2 different workflows before, but now we have actually consolidated them into something much more simpler, so patients can get access to care more easily. So this is how it looks like both in pharmacy versus in clinic. So in pharmacy, the patient can appear at the pharmacy for device. The pharmacy then hands off to the patient educator, which would be like, for instance, me here at the Legacy Southwest Clinic. The educator will then check for diagnosis. Then the educator can provide not only device education, which could be glucometer or blood pressure monitor, but also the patient educator can provide diabetes management, gestational diabetes management, or hypertension education, all in one visit, which is what is the great thing that has come with this alliance. if we don't have a patient educator, or those clinics that don't have a patient pharmacy at their site, we do have patient educators. It works slightly different collaborating with the pharmacy. So in clinic with the patient educator, the patient would first be scheduled with the patient educator. Then they would complete their visit and education, and then the patient educator will actually email the pharmacy to either send a device to the patient's home, or if the patient educator does have it on hand, they can give it to the patient then. But that's how we're collaborating with the pharmacy. So not only are we able to give patients the device when they come to the pharmacy, we can actually also mail it to them if they don't have transportation or time to come to one of our pharmacies. That leads me to my role. So my role here at Legacy Community Health, I am a health educator and project coordinator. So I was, like I said, the pilot program here at Legacy Southwest. I'm not only able to provide device distribution or teaching, also I can provide that health education part, which is important, which we will talk about in a second. Some ways of how this role has, that was created, that has been able to help patient access. So based on everything that we have touched, some of the things that we've done as a group, as a department, to be able to provide that patient access would be revisions to our referral process, which includes increased patient access. We've revised programming, which, like Ashley mentioned previously, we have that dual diagnosis. We no longer have that dual diagnosis. So anyone who comes to the pharmacy is able to receive a free device as long as they have a diagnosis of hypertension or diabetes. We are also working closer in collaboration with providers at each of our clinics to address patients' needs. Patient educators are now located at all 3 pharmacies. So it started with just me here at the Legacy Southwest. Now we provide that same education at both at our Montrose clinic and our Lions clinic pharmacy. And of course, my role here has also been to update education materials. Here are some of our revised education materials that we have done. We have created a diabetes booklet as well as a hypertension patient booklet. All these materials are available both in English and Spanish. We have revised our monitoring logs for both blood pressure and diabetes. And these are all materials that are distributed during that patient education. So when the patient comes in, we cover the device teaching, and then we of course go over how to manage that chronic disease and also how to log that information, because most doctors want patients to bring back these logs at their next visit. So some of the successes and lessons we've learned, the biggest thing is that once a patient gets diagnosed and they're able to come to the pharmacy, the education can be provided at that same time. So that means that chronic disease management starts from day 1 of diagnosis. So patients that are newly diagnosed with diabetes, gestational diabetes, or hypertension have the opportunity to have their questions and or concerns addressed by a health educator, and if needed, elevated to a clinical pharmacist or provider if necessary. I really love this quote from one of our pharmacists when asked how having a patient educator in the pharmacy has helped them. They said that, for instance, in a pharmacy where there's a high demand and high volume, the pharmacist is able to provide limited education. But having the patient embedded educator has been a great help because they can provide more in-depth education and have more time to answer questions, which benefits the patients in the long run. Some other lessons that we've learned are that the Pharmacy Public Health Alliance resulted in streamlined workflows. So creating those workflows that we are now able to complete more services during their time at the clinic It provides the patient a one-stop shop, and it eliminates the clinical staff having to schedule patients to come to another visit where there is greater chance of no-show due to time and transportation barriers. Having this collaboration allows efficient use of patient time for education and true care coordination. Providing accessible free patient education to our communities in a public setting with resources can help improve our community's health and their quality of life. Together, we can help our community promote healthy behaviors and work towards the goal of helping our patients make lasting changes that reduce major risk factors for chronic disease. And I think that's it. We have questions to answer for afterwards.
Thank you, everyone. Yes, please do save your questions for the end of both presentations, so we are sure that all of our presenters have time to present. So now we will transition. If Emily, you'll stop sharing. There we go. Thank you. To our next presenters, Natalia and Dr. Gonzalez Castro. The floor is yours.
Hello, everybody. Wow. Hello?
Yes, we can hear you. And
Okay,
those who are
excellent.
not presenting, if you wouldn't mind turning off your video camera so we can focus on the presenter speaking, that would be very helpful. Thank you all so much. So the floor is yours.
Thank you. Thank you. So today, Natalia and I will be talking to you about the multidisciplinary collaboration for virtual workshops for families of children with ADHD. So we're going to show you the workflow for our model. So here at UT Physicians, we have a team, collaborative team, where the patient is patient-centered, and where the physicians and specialties are also accompanied by what's called a care team. And I'm going to describe the care team in our next slide. So before the care team gets any referrals, our patients fill out a small survey as they walk in and identified by the services from each care team member. So we have a community health worker, a social worker, a health educator, and a case manager. Each one of us has a different role, and the patients are able to check off what they might need and then discuss it with the physician to see what they would need. We can go to the next slide. So one of the reasons that we work together as a care team is because we try to meet the needs of the families and the patients in the community. So as we start to work with our families, we started to see that they were feeling stressed over the challenges at the schools. So as we know, a lot of more schools are finding special needs students in general ed classrooms. So the educators are also challenged by the needs of these children. So when we started getting the referrals from the doctors, we can go to the next slide, thank you. We started to see last year, especially during the pandemic, that our patients were seeing the doctors, but they weren't being able to see the care team. We weren't able to give them the information we needed as quickly and as available as they could use because we were all quarantined. We did also notice that parents had a lot of questions about getting services in schools, and a lot of the parents did not understand the system. The pediatricians had parents that did not know how to get help in school. So just requesting for an evaluation for their child or asking for accommodations or modifications were very unfamiliar terms and ideas for our parents. And then families were isolated. So we sat down and started thinking, how can we assist these families and get connected across the board with them? So we came together and I invited the social workers of other communities, clinics, because there's a care team almost in every single clinic, UT Physicians. So we divided up the roles as social workers and we created what is now the Educational Corner. This is a platform or website where within UT Physicians, families can go and they will find information about their schools. So on the next slide, you will see the videos that were created. We ended up creating videos for the families to look at. They're 3-minute videos. They're done by different social workers. And with the community health worker, with the health educator and myself, we organized it with the media. And we created videos like parent-teacher conferences, practicing self-care, understanding response to intervention or Section 504 and IEPs, being your child's advocate, accommodations and modifications in the school and environment. And then we're working on slowly translating those videos into Spanish. So we'll eventually have them out there in both languages. These videos are out there for families to go at any time. And at the same time, we created a resource page for the families so that they could come in and get additional information. When we first started, we were just thinking about families in general. Then we started collaborating with a different department at UT Physicians. Natalia, the health educator, and myself, we got connected with the behavioral therapist, and we got connected to a psychiatrist that was focusing more on families that had children with ADHD. And at that point, we added the ADHD resources, but then we ended up creating some workshops. And in the next slide, you'll be able to see how ADHD data is impacting also children with special needs. So we have about 5.4 children between the ages of 2 to 8 diagnosed with mental, behavior, or developmental disorders. Then we also have in 2016, that comes out to about 11% of the United States, 11% of children with ADHD in the United States, which is about 6.1 million American children with ADHD, which in 2003, the CDC stated the 43% increase in ADHD diagnosis. It's not that it's a difference, it just means that people are more aware and are getting more assistance and help. And we need to be able to provide that support to our families in the clinics because they come in with those concerns, and a lot of times they don't know what to do. And so as social workers and care team members, health educators, we're able to be there for them. Next slide. So again, one of the goals when we connected to the ADHD program within UT Physicians was to make sure that none of these families are falling in between the cracks, because ADHD sometimes is not seen as a real mental health or a real diagnosis. So we wanted to emphasize and educate parents on how to help their child in their school. So that's where Natalia is going to pick up and talk to you a little bit more about what happened after we got connected.
Yes, thank you, Leticia. So a little bit about the workshop format. As Leticia mentioned, we were connected with a clinical psychiatrist who created a curriculum in Spain, wanted to adapt it to his work here in Houston. So we met several different sessions. We decided that the format of the workshop would be 4 one-hour sessions. We were in the midst of the pandemic, so the sessions, I believe his original vision was to hold these in person, but it was shifted to the virtual format. There were 4 different topics, 1 topic per session. It started off with what is ADHD, a very general overview. The pediatric psychiatrist facilitated that session. Then we had a session on therapeutic intervention, more like behavioral techniques for managing children with ADHD. That was presented by the clinical therapist. The 3rd session was about academic interventions or ways to work within the school systems and get support in the schools. And that was presented by the medical social worker, which was Leticia. And then the final session was ADHD and medication management. And that again was presented by the pediatric psychiatrist. All 4 of these sessions were designed to be taught very basic knowledge, but also explain and offer time for question and answers, which was really helpful for a lot of the parents, especially when it comes to medication management. So in terms of our target community, we were targeting patients, parents with children who see either pediatricians or mental health providers at UT Physicians, but also open to the community. We recruited directly from families who were referred for assistance, like as you saw in that form that we use, and also from referrals from providers that were referred to social workers for assistance with school evaluations. We also reached out to community educators in schools and also Spanish-speaking parents. So for the parents that were Spanish-speaking and unable to attend our English sessions, we directed them to the educational corner where we are having these videos uploaded kind of one by one. They're created, but being uploaded that are in Spanish. So in terms of virtual programming implementation, just brief background, UT Physicians offers wellness classes in person in several different community clinics. In May of 2020, we shifted those programs to a virtual platform. So when adapting virtual classes, you have to take into consideration the target population. In this case, our target population is parents and educators, which is a little bit unique. Lots of our other programs are targeted mostly towards older patients or are most popular amongst our older patients. So this target population is a little more familiar with digital communication just because of virtual schooling. One of our barriers or our main concern was Zoom fatigue. We decided to offer this program in the early afternoon. We figured that would be the best, especially for parents. A lot of times you get home from school, the kids are home, it's after 5, the last thing you want to do is log on to another virtual class. So this way we were able, once people had a free hour, whether it be a lunch hour or while they're home and the kids are still participating in activities, they can participate in the classes. We use adult education techniques, which are basically keeping sessions short. Adult attention spans aren't as long as we think they are. 1-hour sessions are perfectly digestible, and we keep them interactive. So we encourage the participants to use the chat, to unmute themselves whenever they want to ask questions. The facilitators ask open-ended questions in their presentations, which warrant a lot of response. So that is helpful. In terms of recruitment, we used flyers in clinics. These flyers were distributed to providers, distributed to social workers and other health educators. They were also placed in patient rooms. So in the pediatrician room, social workers, psychiatrists. We also, and what's vitally important, is partnering with the providers. So having child psychiatrists refer patients to us, pediatricians, and other social workers. The community health workers that are in the clinics were extremely important in developing connections with schools. They have relationships with local schools because of their outreach efforts that they do. So that was extremely important for bringing this program to the schools. And we even had an entire school district, a lot of their educators attended our sessions, which was great. We scrub gap lists. So gap lists are lists of clinical measures that the clinics are expected to achieve. And there is one for ADHD. So it provided a perfect area for us to kind of click on that patient list and see patients that have ADHD as a diagnosis charts. And that way we are able to recruit directly from there. And the best, of course, is a warm handoff from provider. That is the most effective way to recruit. And a lot of our participants came from the clinic that the clinical psychiatrist services. As you know, if your doctor tells you that this would be a good idea, you're more likely to do it. And so that is one of the most important techniques that we can use. The best practices for virtual health or for virtual programming. We utilize several platforms to manage them. So we used Tavoca to send out text messages. We used Qualtrics to develop our pre and post surveys. And we use WebEx, that's our organization's accepted platform for virtual classes for patients and participants. Especially for adult participants, you want to enforce reminders. So for a lot of people, nowadays calls aren't effective. So we text messages may be more effective. And we also include multiple access points for class. So in addition to receiving emails, automated from WebEx that can kind of get lost in your inbox, we were including the links in the text messages that were a little bit more personal. Cultivating relationships with local schools, that's something that I touched on briefly. This proved to be a really great partnership and provided a whole new context of participation from the educators versus parents. And then multidisciplinary collaboration within the clinic. So including providers, including the CHWs, including the health educators, that I think brought the class to be very successful. And utilizing the functions on WebEx, which, like we mentioned, encouraging participation through the chat. So results, since programs start in January of 21, we've completed 2 full cohorts. So like I said, this is a 4-session class. We space them apart every other week. So 2 full cohorts have been completed. 1, we're near completion. We have 1 more session. We also offered a one-time 1-hour session for back to school in August. And total unique participants so far are 73. Total parent or family participants are about 43. As you can see here in the breakdown, a large number of those of our participants are also not only from the community school, which is in the red, but also members of our UT family. So other staff members join, we even had staff members join, we had other fellows or residents join to observe. And in terms of next steps, we are continuing to recruit and promote the workshops. We're evaluating, we're probably going to take a break for the rest of the year because of the holidays, and then see what will happen for 2022. The other department in psychiatry is thinking about expanding this programming for adults with ADHD. So changing the messaging bit, of course, but adapting it for adults. Continue to build relationships with community organizations, especially those that service families or children with special needs. We want to continue to translate the video materials. So we have completed recording and are finishing up, our marketing department's finishing up on the content for posting the videos for people who aren't unable to join the class during class time. And we'd like to create either peer support groups of virtual attendees. That's something that we saw in a lot of the feedback. Participants really the program, but they felt that they want more. They want more time to get to, to work with each other, talk to each other and learn more. And then also building an educational support group for people who have ADHD. So this could be more like adolescents or adults. And that is it.
Thank you all for your presentations. I invite all of our speakers now to actually turn on your cameras so all of our participants can see you, and to unmute as we start to hear questions from the audience. You can put your questions in the Q&A box and we'll give folks a minute to add questions for the group. If possible, when you're asking a question, if you want to direct it to one of our speakers, please do that in your question. Otherwise, we'll open it to all of the presenters. So please do type in your questions at this time. Give folks a minute to do that. As we give folks time to pose their questions to the group, I have a question for the group, and this is to all of the presenters. You both presented initiatives that had as one of their elements of success a interdisciplinary collaboration with others in your organization. For those who are participating today that are pursuing or want to pursue a similar interdisciplinary partnership, what recommendations would you have in terms of pursuing that work within diverse and different disciplines within an organization? Anybody wants to jump in on that one?
I can jump in. Thank you.
Great, thank you.
You're welcome. I think when we first started introducing the care teams into the clinics, it was a new concept for the physicians and they didn't know what each role was. So I think one of the biggest things is to definitely make sure that if you're bringing in other disciplines, that the physicians understand what those disciplines specific roles are so that they know what to look for and how to collaborate with you. And it also takes the members of the team to advocate for themselves. So you do have to speak up and say, hey, this is something I can assist you with or I can help you with. So it goes both ways.
Thank you. Anyone from Legacy want to share their lessons learned on interdisciplinary collaboration?
Sure, I'll jump in. I think I'm the only person unmuted. So on the Legacy side, we devised our workflows and we actually started the work, and then we realized that there was a lot of gray areas that we were identifying with this revised workflow and the way we wanted to offer these services for our patients and in collaboration with our pharmacy department. So our public health management team actually got together and developed a full list of agreements in various scenarios based upon the patient's insurance status, if the patient had a prescription to a Legacy pharmacy or if the patient had a prescription to an placement of pharmacy, and then what other needs need to be considered for that patient. So I think us having that full list of agreements really did help our team because, for example, Emily is at our Southwest clinic, but then we have a different team of pharmacists at our LMC clinic and a different team of pharmacists at our Fifth Ward clinic. And we just wanted to make sure there was some consistency across all organizations. And so, I mean, all aspects and all parts and all the pharmacies within our organization. I think for those that are on the call and have worked on workflows before, especially in a clinical setting, each clinic sometimes puts their own spin on a workflow. So it really helps to have a clear set of agreements. I think that has been a great benefit for us all. Alejandra, Emily, anything you wish to add?
Yeah, I was going to add too that it helped a lot to have the collaboration of Emily as the health educator project coordinator, because she gives us, you know, a different perspective. She's there at the clinic every day. She's, you know, the one that completes these educations. So, you know, having her on the team was definitely a great contribution because we were able to, you know, identify all these gray areas. And she, you know, she would always, you know, great about telling us, wait, what about this? Wait about that. So it's also very important too to be I guess adaptable to change and be okay with you know, there's going to be changes in workflows and there's going to be gray areas, but I think just having a team that consists of, you know, partners that are always available and ready to answer questions. You know, our pharmacy department was great about that, and having a health educator project coordinator really helped too, just because we got that perspective from Emily that does her role every day.
We do have a related follow-up question in the Q&A box. Thomas asks, and for both groups, if someone would like to address this, who takes the lead in organizing a collaboration? Or who would you recommend takes the lead? Or who took the lead in your collaboration?
I can speak a little to this. I think it's really important to have buy-in from supervisors, from leaders. I think that's very helpful. I think it also really depends on your relationships and kind of the dynamics within either the clinic or the organization. I think as a collaboration, it should be, you know, unique in our case, we had people from, you know, different disciplines. So we had the clinical therapist reaching out to the other therapists, our medical social worker really reaching out to the social workers, and a provider that had that connection to the residents and the fellows and the other providers. So really playing onto each other's strengths and each other's relationships to kind of facilitate that collaboration. But for initial collaboration, especially in an organization as large as UT, sometimes we work in silos. So I think as an organization, we're trying to improve that. And so that kind of our leadership is helpful when it comes to that.
I'll echo Natalia's sentiments in regards to the leadership aspect. At Legacy, our public health and pharmacies teams actually roll up to the same vice president. So we are all under clinical integration. And so we are constantly working on ways to ensure that both teams are working together well to make sure that we are benefiting our patients.
Another follow-up question specifically for our UT team. How did you establish and solidify your partnerships with providers? I know this was asked of UT. I think Legacy folks probably can talk about this as well. To finish the question, oftentimes providers seem too busy or forgetful. So how did you work with your providers to launch your initiative? And we'll start with Natalia and Dr. Gonzalez-Castro, and if there's time, then I'll punt it over to the Legacy team as well. I know y'all have struggled with this too.
Yeah, I mean, I know we're very familiar with this. I think like what Leticia mentioned, our care teams are pretty well integrated into at this point, are pretty well integrated into most clinics. So that relationship is there, but even so, providers are forgetful. I know for our first cohort, we had providers sending us referrals. Second and third, not so much. It's, I think, constantly reminding the providers, constantly reinforcing that program is there. And this goes for all of our programming, not just for the ADHD program. Constantly reminding them that these programs exist, how to place a referral, here we are. And it takes some persistence. I don't know, Leticia, if you want to add anything to that.
I think definitely the relationship with our providers, but also as a clinic as a whole. I mean, they knew we would support each other, and from the moment they walked in, our front desk was talking to them about a program coming up, or when they were being discharged, they're bringing up the program. The MAs were bringing up, especially if they knew that one of the issues for that patient pertained to this specific class that we're doing. So it takes the whole team to continue to build the patient up. So I think that's part of what has worked for us. The care teams work so closely with everyone that we're not just one discipline, we're all a team working together.
So a question specifically of the Legacy team. Did Legacy consider using CDEs to provide glucose and diabetes education?
Lucky Legacy, we actually have 2 CDEs in our RD department, or in our RD team within the public health department. So our in-pharmacy patient health educators provide health education services to patients that have a lower A1C. If a patient has a higher level of acuity or a higher level of need, then they actually get their patient education services with an RD. And then that RD can either provide a device as a part of their appointment with that patient, or if that RD is seeing a patient at one of our locations where they have the pharmacy, then they could just direct them to the pharmacy, and then our educator in the pharmacy will specifically do the device teaching aspect of the education. So we are very fortunate that we do have 2 CDEs here at Legacy as well. Good question, thank you.
I'm going to ping pong back over to the UT Health Group. UT, did you have your legal team approve the usage of TSOPHE? I hope I've said that correctly, in terms of patient privacy to send email or text messages, or was that a platform that was already within use?
Yes, I mean, as you can probably imagine, we are a large system, so there's lots of red tape. So TSOPHE is a system that UT uses as a whole for patient reminders. And right around when we were switching over to virtual programming, we achieved all the permissions in order to use it for our wellness class reminders. So we use a special spreadsheet to upload patient data. And through that, we ensure that patients only see their own name. They don't see any other patient names. The same thing goes for WebEx. WebEx sends out emails as well, but it's through the WebEx platform, not through our personal emails. So they don't see our emails attached to it. And that is, again, something that we had to get approvals for through various departments. And that happened when we switched over to virtual.
All right. Another question for the UT team. I love this, and I think the Legacy team could probably help answer as well. How do you break down these darn silos? where physicians, nurses, social workers, etc., are like, I love this question. I love how I could just hear someone saying it, are like, we provide this information and not health educators. There's always a gray, uncertain area embedding health educators in the clinic setting. I think that's a very true statement. Certainly where there is gray between the roles of different parts of a workflow and who does what, and how do you get different parts of that workflow to then hand off to other parts of the workflow. So to honor the question, UT folks, if you'd like to talk about how you break that down, how do you create workflows, and then, I'm sorry, handoffs, and then I'll punt it over to the Legacy team to share their experience as well.
Well, I'll speak to that, I think, a little bit. I think we're constantly aware of the workflows, and we're trying to make sure that we're part of the team. So we huddle every day in the mornings. And in the huddle, we discuss what's going to happen that day or who we need to discuss and bring up. And we also scrub at the end of the day so that we are ready to talk the care team to all the physicians. And then we individually check in with them in the mornings about a patients that we need to. And then we make sure that we remind them. We use Skype. Well, it was Skype. Now it's, I forgot what it's called now. We're communicating throughout the day. Like, I need to see this patient, we need this other patient. So, and then when we're in the rooms with the patients, they call us, and when we walk out, we check in with the MA or the front desk that we're going to see them again or not see them. So it's a lot of communication throughout the whole process of the workflow that already exists, but that we come into the different pieces of it. So each different discipline is coming in to see the patient at a certain moment. And then our physicians are just used to it. They know to call us now. There are other clinics that have more difficulty, but we're at a Jensen. We're at Jensen on the north side, and our clinic is pretty consistent with those workflows of calling us in and getting other disciplines to work with the patient.
And I think kind of like what Leticia is mentioning, the workflow is so important. That is something that is set and constantly updated by leadership. So it's something that is distributed to all the practice managers, all the providers, all the care team members, and it lists the roles. Like, what is the health educator going to talk to a patient about? When do you call a social worker? How do you place that referral? And it is updated. We try to do it annually, I believe. Leticia, correct me if I'm wrong. Yeah. And that is distributed to everyone. So it's not like, we just plop a CHES in a clinic and then there's, a lot of confusion as to what each person does. And we never want to step on toes of the providers. And obviously we're not going to speak to things we don't know about. So the workflows and like Leticia said, the relationships are what's really important. And the silos are a work in progress, but I think that's
Well, we are short on time. I think we have about a minute left. If someone from the legacy team wants to share their advice for breaking down silos, seems to be a theme of today's session.
I'd like Emily to chime in on that because I feel like she's done a really good job with this.
So here at Legacy, trying to break down those silos, I guess you could say, would be just trying to collaborate with the other departments. So getting to know the actual providers and saying like, hey, I'm here, this is what I do, and this is what I can help you with. So trying to collaborate with my OB providers as well as the adult medicine providers here and letting them know like, I'm here as a resource, please use me. That has been super beneficial, as well as having great management team to be able to disseminate that information to the provider. So not only does it happen at the clinic level, but also at that, next management level that I don't have access to. So being able to disseminate those workflows and things like that to let them know that we do have the service here available.
Great. Well, I want to thank everyone for your presentations today. My last piece of information is for those who are seeking CEUs for this session. I am now going to put a link in the chat for the evaluation form that you'll need to complete in order to receive your CEUs. So thank you for joining session 5. Next on the conference, we have our closing remarks, and I invite you to stay for those. And thank you again to our speakers.
Thank you, Jen. Alrighty, we're going to move straight into our closing remarks. Let me go ahead and okay. Alrighty, so with the closing of our last session, we want to take some time to thank all of our presenters for today, those that were present from Texas and those that were able to join us from other states. We want to thank Dr. Opusunju for presenting on the importance of community empowerment and health equity. We also want to thank all of our presenters, poster sessions, oral sessions, and networking sessions. We hope that these presentations, despite being virtual, resemble an in-person conference. On behalf of TSOPHE, we especially want to emphasize that networking and exchanging contacts is encouraged. A critical component of health education and the public health field is collaboration. Collaboration is especially important during these challenging times, as it is extremely important to work through the uncertainty of our work as a team and united workforce. Most importantly, we must rely on the hope, motivation, and support of our colleagues to continue to move this work forward, even after we have surpassed the COVID-19 pandemic. As a reminder, our TSOPHE conference is biannual, which means that we will not host a conference again until 2023. However, there are several ways to stay involved and connected with TSOPHE. This fall, we will open our call for TSOPHE board nominations. If you are interested in serving on our executive board as a general board member or student representative, please keep an eye out for that announcement. We will also continue our webinar series through 2022 and will feature a handful of webinars in November and December to wrap up the year. Be sure to follow us on all of our social media platforms so that you stay up to date with any events or announcements that we share. I also want to give a huge thank you to our TSOPHE board and everyone that has helped with this conference, marketing and communications chairs, presenters and frontline workers. I want to give a personal thank you to my husband, my family, my mentors and advisors, Rachel Sanchez, Amy Nussbaum, Dr. Amstad Meyer, Dr. Basunju, Dr. Mojica, and Dr. Barra Medina, who have all helped shape who I am as a leader. This was the first conference that I have ever planned, and I have learned more than a thing or two about how to plan a conference during the pandemic. So all of this would not have been possible without all of you, your participation and your engagement throughout this conference. And with that, I would like to thank all of you for joining us this year for our conference on Shaping the Future, Empowering Communities Through Health Education. We hope to see all of you in person in 2023. Thank you.